Pardon?
Luis, if you don't mind, we will record your lecture.
It's okay. Oh, now. I just realized that what's on your screen is not what's on my screen. Sorry, give me half a minute of technical issues. Okay, I can do that, but okay. I can't skip across it, unfortunately, sorry. Let me just, here's a sneak show for everyone.
Yes. Oh, this is still not the PowerPoint show.
You're not getting the PowerPoint?
No, not yet. So this is just the PowerPoint.
You still got the first page?
We already moved to the I don't know which page is this, but it's still not in the screen show, you know. I mean, that's still not in the PowerPoint show.
Right. Okay. Let me just stop share. Sorry. Sorry, everyone. I can do the PowerPoint. I can do the screen one. I don't know what the difference is.
Probably you choose the wrong screen, or yeah. And then at the bottom, Luis, if you see there is a symbol,
So you're now seeing this screen. I have 3 screens. I'm sorry.
You have so many screens.
And if you're seeing the slides progress now?
Yes. Not yet.
In the PowerPoint?
Good.
In the slideshow? Yeah.
But still not in the slideshow mode.
It's still not in the slideshow because I'm putting it in the slideshow mode here.
Margie.
Good morning, Dr. Adrianta.
Morning.
Yeah. No, it's sliding it there, but not here. Let me take it off.
Yes.
No. Stop here. Yeah.
Ini arek wedok-wedok iki.
If I go into the
This one is good.
So this is now, yep.
Yeah, it's work. Yeah.
Okay, so you're seeing this screen. Okay, sorry. Sorry.
That's okay. Technical thing.
One day.
Good.
So
Do you want to start now, or probably can we wait just 5 minutes?
yes, please.
Because I say that everyone's still not joined yet.
That's okay. Everyone can see my technical sideshow. It's like, you know, you go to a music show and the musician has to tune up their guitar before they start. So
yeah. So that's the yes. Sorry. Yeah, okay. Itu gimana?
Syama.
I think that we can start now. Luis, just want to give a short introduction before you start. Okay. So, good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. I hope all of you are in the healthy conditions, and also you, Professor Luis from in Perth. So first, I would like to welcome you all to this special GRACE lectures, and thank you for joining us with us today. So this event, just to let you know, so this event is a part of the elective block in the module of the Exercise for Health and also Sport Medicine for undergraduate medical students of Faculty of Medicine, University Airlangga. But we also invite everyone who have interest to exercise or sport to this lecture. So before we start, I would like to introduce our special lecturer today, Professor Luis Naylor from the Cardiovascular Research Group, School of Human Sciences, Sport Sciences, Exercise and Health, the University of Western Australia. Professor Naylor's research focus is on cardiovascular adaptations to exercise training, and also the implementations of this work to optimize the clinical outcomes for at-risk populations, with an emphasis on patients with advanced heart failure, obesity, and also the adolescent with type 2 diabetes to generate a multifaceted understanding of cardiac and also the vascular exercise physiology. Other than that, Professor Naylor is also involved in basic science research to add further mechanistic insight into the regulations of the cardiovascular system. And today, Professor Naylor will be talking about the exercise in cardiac patients. So without further ado, I would like to invite Professor Naylor to give her lecture.
Thank you very, very much. Thank you so much for that. And thank you for the invitation to speak as part of this lecture series. It's quite an honor to be able to do this. So cardiac patients, the heart and exercise is something that I'm very passionate about. So anytime anyone asks me to talk about it, I always say yes. And really what I wanted to focus on today is not just why we exercise, everyone, the benefits of exercise for the general population, but really specifically for this group of patients who've got cardiac disease already. So up until about the 1960s, so probably within the lifetime of your parents, if someone had a heart attack, they would stay in hospital and not move. We thought that by exercising them, we would provoke and make their heart disease worse. So really in the last 60 or 70 years now, we've had some huge advances in the way that we treat these cardiac patients. And that's really what I wanted to speak to you all about today. So I've titled this Exercise for Cardiac Patients. And the gentleman who is up on your screen now is actually one of our patients. You might see that he's wearing a bag on his shoulder and what looks like a bit of a backpack on the front of his lap. That is actually a mechanical assist device. So it's called a left ventricular assist device, which is a machine that essentially cores into the bottom of the heart, so into the left ventricle, and it takes the blood out of the heart and puts it directly into the aorta. So this is a gentleman with end stage, very advanced heart failure. And as you can see, he's happily exercising. So, you know, had we been talking about this 30 years ago, we probably would have thought that he was too unwell to exercise. So some of the things that we're going to touch on today is knowing, is there a time when your patient is too unwell to exercise? Or is every patient going to benefit? And how do you modify your exercise prescription so that they can also get it? So let's start. These are the benefits. There are countless benefits of exercise for patients who have got established heart disease. I've put out this study, which is published in the Journal of American College of Cardiology, because it's a big impact journal. So what you're seeing here is the data. So the NNT is the number needed to treat. So the benefits of exercise is that it reduces cardiovascular mortality. For every 37 patients who exercise with heart disease, one of them will save cardiovascular mortality. So if you have 40 or 50 people, then one and a half people on average, you will be saving them from premature death because of the disease, just by exercising them. If you want to reduce the number of people who come back into the hospital, so they already have cardiac disease, by exercising them, you only need to exercise 22 to save one person having to come back into the hospital. And so that's quite remarkable in terms of the statistics. The data that's up here is also published in the Journal of American Medical Association, and it shows the number needed to treat for statin therapy, so the medication that we use to treat high cholesterol. And I could imagine that even some people in this lecture are on a statin, or at least someone in your family you know of is on a statin. Now, the reason so many people are on statins, and it's almost the top use drug in the world, is because you only need to treat 21 people for there to be a benefit. So every 21 people, you've saved one person's life. But have a look at the benefits of exercise. 22 people to save one person's life. That's quite compelling, in my mind at least. However, it's something that, as I said, I've already said earlier, we're a little bit scared to be doing it because we think that there might be some adverse side effects or some making things worse, or we even think that it is not beneficial. So what's the point? So hopefully by the end of this morning, I've been able to convince you that it is important and very beneficial for everyone. So this data here shows the benefits of regular exercise training. So what we've got here is what we often refer to as the weekend warrior exercise training study. And a weekend warrior is an individual who does all of their exercise. They meet the recommended daily, weekly amount of exercise, but they do so in 1 or 2 days on the weekend. So they're busy working Monday, Tuesday, Wednesday, Thursday, Friday, and then perhaps on Saturday and Sunday, they go out for a long run or they play football with their friends. So what are we looking at here? The information that you're seeing is a graph of the hazard ratio. So a hazard ratio of 1 is our reference group, and we've done that as the blue group here. So the sedentary individuals, they do not move on average. They're not getting their exercise through the week. So they have a hazard ratio of 1. In comparison to those individuals, everyone in the gold bar, the black bar, and the bronze bar are doing some amount of exercise. And hopefully you'll first be able to see that by doing any exercise, you are reducing your hazard ratio of having a cardiac event when you are exercising compared to those who are sedentary in the blue. However, this is where it gets really interesting. When you look at the gold group compared to the black group, so the black group are those weekend warriors that I spoke about. They meet the recommended minimum amount of exercise, but they only do so in 1 or 2 days. Their risk is reduced compared to those who are sedentary and don't do any exercise, but it's actually slightly higher than the gold group. And the gold group is those people who do a little bit of exercise every day, but they don't yet meet the guidelines. So they might only do 10 or 15 minutes a day, but they do so regularly. So this was a real big moment for the exercise community, the researchers here. And we've taken home from this that when working with your patients, you really need to be emphasizing regular and daily, rather than just saying you have to do exercise. So rather than saying we need to do 150 minutes of exercise throughout the week, what I would like you to be thinking about is that you're encouraging people to do a little bit every single day. Because the risk then of having an event while you're exercising is going to be reduced if you do it all the time. The other really important thing to remember is it's not just about exercise. There is also physical activity. So the difference between exercise and physical activity is that exercise is planned physical activity. But you've got 24 hours in the day, and you might exercise. Even if you're really fit and you're really dedicated to your exercise, you might spend 1 or 2 hours on most days exercising. What about the other 22 hours of the day? So again, a really simple thing to do is to explore the way in which we can every day fit exercise or physical activity into our schedules. And this is going to make it more attainable so that every day we can do something. And when we think about exercise, it's not just going for a run, going for a swim, going for a bike ride, but what about the other things? Working around the house, walking to and from work or from school, and just going around and doing something. The other really important thing is that we also add in some strength and some flexibility exercises. And another thing that we have perhaps not spoken about so much when we think about exercise and activity is just reducing the amount of time that we sit still. So by reducing our sedentary time or inactivity up there on the top of that pyramid, you can actually get many of the benefits as well. And by fitting these into your usual routines, then you're going to be assisting people to not only be exercising, but to be exercising regularly, and therefore be reducing the likelihood of having an event during exercise. So you're reducing the risk. As I said, strength activities is very, very important. And every guideline from no matter where you are in the world recommends that you do muscle strengthening activities on at least 2 days every week. So be thinking about that. And again, I've given you 2 examples here. It doesn't just have to be in the gym, lifting weights. Walking up and down stairs is a great way of doing some strength, some muscle loading exercises, as is walking in the water. And there are many different ways that we can think of this where you don't have to be thinking, oh, it's so boring to be in the gym. And this is why strength is important. So I don't know if you use McArdle Catch and Catch as your textbook, but this is out of McArdle Catch and Catch. So this is what we teach our first year students. This is a study where they have looked at grip strength. So you hold onto a device and you see how strong your muscle strength is for holding onto the grip strength parameter. Then 25 years later, they followed up these individuals. What you're seeing here is in yellow, the people who were in the 3rd lowest strength for the hand grip strength. And the purple are those that have got the highest 3rd, and then the middle ones are those that are in the orange in the middle. 25 years after testing their hand grip strength, what you'll probably see here is that those with the highest strength had the least limitations, whether we're talking about being able to get up out of a chair, or doing your heavy household work. In every single one of these graphs, the purple group have got less limitations to doing these. And this is 25 years into the future. Whether it's eating, whether it's independently going to the toilet, having a bath, dressing yourself, or walking around and doing the shopping that you wanted to do. So don't discount the importance of a little bit of strength muscle exercises as well. And therefore, the American Heart Association scientific statement, which came out in 2017, published in Circulation, tells us that working with older individuals that have got cardiovascular disease, you really need to prioritize their functional capacity. So the primary outcome, what the patient wants to get, as well as we as practitioners would like our patients to have, is to enhance their functional capacity, so that they can preserve independence and quality of life. So by focusing on the functional fitness, like walking up and down the stairs, getting in and out of the chair, etc., you will be able to make sure that your patient is going to have what we call successful aging. So as you get older, you are able to look after yourself. You are able to stay at home and cook and to continue to do all of the things that you would like to do. There is a number that's associated with this, and for those who are familiar with a VO2 max test, a VO2 of somewhere around 18 mils per kilo per minute, which is about 5 mets, so a metabolic equivalent, is going to allow you to successfully age and to have your independence and quality of life, or at least according to Circulation. So just to bring it all home, and hopefully I've already convinced you there are so many benefits of exercise, but we might not always think about what the benefits are. So this slide, again, a recent publication from the Journal of American College of Cardiology, summarizes the benefits of exercise for the cardiovascular health. And you'll see that it's not just the heart. So in the top right-hand corner of the slide, you've got the benefits of the heart from exercise. You're going to increase your cardiac output so you can send more blood out to your body and to your brain at lower pressures and a lower resting heart rate. You're also going to have improvements in the sympathetic nervous system. So you're reducing that sympathetic tone and you're increasing the parasympathetics. There are benefits to the kidneys. There are benefits to pretty much every organ that you could think of or every physiological system, through from the blood vessels to the lungs to the muscles themselves. So when we're thinking about a holistic program for our patients, hopefully we are thinking that exercise is an adjunct to the best therapeutic medications that we can give them, and that the benefits of exercise are on par with some of the best medications that we have. Okay. I'm happy to take questions as well. So if you have a question, just pop your hand up. Otherwise, I'll just continue to go. So these are the guidelines. I've taken the guidelines from all around the world. So when working with cardiac patients, the European guidelines, Canadian guidelines, United States, Japan, Australia, New Zealand, anywhere around the world, they have their own guidelines of exercise. And you can see that they're somewhat similar. They're generally around 1 to 2, maybe more sessions, depending on which part of the world you're in per week, and those sessions being somewhere around half an hour or so. The guidelines give us some great guidance, which is why they're the guidelines, about how to prescribe the exercise. So if we look at the intensity there, Australia has low to moderate intensity, but the others say that it's a percentage of their peak, which insinuates that you need to know the maximum capacity of every person that you're going to be exercising or working with, which is not going to be the case. In most places of the world, it is not standard that you will have a maximal assessment. So I'll talk about how we might be able to adapt these guidelines to fit. Now, the type of training so that you can do, MCIT is moderate continuous interval training. So that is going out for a long walk, that is doing something where you're increasing your exercise, your heart rate while you're exercising. But there's probably most of the guidelines, except for Japan there, surprisingly, that also have resistance, so strength training as part of the guidelines. So as I said, while they're guidelines and they're fantastic, and these are designed to keep your patients safe, it's not always the easiest, because when someone's sitting across the desk from you, how do you know what 40 to 85% of their heart rate reserve might be, or 80% of their peak exercise capacity? So as I said, we'll talk about that a little bit as well. But really, this is around the agenda of risk and benefit. So is exercise safe for everybody? As I've already told you, there is an increased likelihood of having a cardiac event while you're exercising. And that is true for everyone, whether you are a child or whether you go through and you've already had heart disease, or you might be in advanced heart failure, like the patient that I introduced you to earlier. So how do we then, as practitioners, balance the risk to the benefit? As we know, clinicians, our number one motto is do no harm. So if we think that exercising an individual is going to put them at greater risk than the benefit that we are able to give them, then we would be very cautious and maybe not exercise that person. But I've also put in here this little cartoon character here wearing his multicolored glasses to remind us that being safe is not always just black or white. There are many different shades to safety. And so by being able to predict what the risk factor might be, we can mitigate those by doing certain things. So that's where I wanted to spend the next couple of minutes talking about how we can mitigate these risks and also identify what they are. So these are the absolute no-nos when it is not safe to exercise an individual. There are not many of them, so we can commit them to memory. So the first one, when it's not safe to exercise a person, is if there are significant ischemic changes at a low level of exercise. So what is a significant evidence of ischemic changes at low levels of exercise? So ischemic heart disease, very quickly, is when there is a blockage in the coronary arteries, So the oxygen that needs to be delivered to the heart tissue, the myocardium, is inadequate. If you're going to raise the demand for myocardial oxygen, then you will already be putting that person at higher risk if there is some blockage to not having adequate oxygen supply, because you're reducing the blood flow through the coronary arteries. So the way that we can think about this as a physiologist is what we call the rate pressure product, or the RPP, or the RPP, or the R double. There are many different ways, but a rate pressure product is basically your systolic blood pressure multiplied by your heart rate. So at any time, you can work out how hard the heart has to work by multiplying the systolic blood pressure by the heart rate. And if you are doing an exercise with an individual and they start to get angina or any symptoms of ischemic heart disease, then you say, okay, what's their blood pressure at this time and what's their heart rate? And that is their limit. You cannot go beyond that point because you'll be inducing ischemia and potentially a myocardial infarction. You also need to be aware of the symptoms that come at this time. Remember, there are individuals like those with diabetes who have what we refer to as silent ischemia. So silent ischemia is that there are no symptoms indicating that there is not enough or adequate blood supply to the heart tissue. But otherwise, patients might feel that classic chest pain that's radiating down the arm, up into the jaw, maybe across the back of the shoulder blades. Some women particularly are more likely to feel nauseated, but they are the symptoms that are just telling them that the blood supply to the heart is no longer enough to maintain the myocardial oxygen demand. You also need to be aware of...
I have a question.
Oh, yeah, sorry, yes?
Sorry, I'm having sore throat. My voice is a bit rough. My question is, there is certain sports people during extreme sports, they suddenly have a heart attack and they may pass out or die. Is that related to this? Because based on certain things, they don't really have any heart problems.
Correct. So thank you for that, Kashmita. Generally, we find that the risk of heart disease is or having an event while you're exercising depends on your age. So if you are about less than what I'm going to call middle-aged, and I apologize for those who are above middle-aged, 35 or younger, then usually the event, like these athletes, is because they have a congenital abnormality. Their heart has got what we call a hypertrophy, so a left ventricular hypertrophy, where the heart tissue itself is really large. And that puts them at susceptibility for an arrhythmia. So they have a cardiac arrest, where their heart stops. The electrical activity is no longer able to get the heart to beat so that the blood flow can come out. If you are over about 55 or 60 and you have a heart attack during exercise, that's more likely to be because of ischemic heart disease. And so that will be your classic angina. That will be because of a coronary artery blockage. And that's just statistically speaking, because while we know that ischemic heart disease begins, not just as a child, but even from your grandmother. So there's a whole thing of research called developmental origin of health and disease. And there is a lot of evidence to show that your grandmother's health status actually influences whether or not you will develop cardiovascular disease later in life. And there is some evidence also that while the baby is in the womb, in utero, there is some evidence of these early changes of atherosclerosis occurring. But generally, we're looking at a blockage of at least 70% before cardiologists would even open it up. So it's quite a substantial stenosis before it gets treated and to this stage. So the second point here is actually that increased risk of arrhythmias. Does that answer your question? All right, I'm going to assume. Yep. Okay, thank you so much. Thank you for asking a question. So then when we look at exercise capacity, we know the more fit you are, the better your chance of survival. So when we are looking at things, remember when we had about a 5 METs, that was the publication that showed you that that is where your patients could have independence when they were elderly, etc. So if you are to exercise someone, you can determine how fit they are. So 1 MET is the amount of metabolic equivalent of rest. So just sitting around, and for all of you, some of you might even be almost asleep, you will be burning 1 MET equivalent of energy at the moment. For me, because I'm giving a presentation, it's probably a little bit higher. But if we were out there, a world-class athlete might have the equivalent of about 20 METs, and 1 MET is roughly 3.5 mils per kilo per minute. So if you can move your patient up just 1 or 2 METs, so that's the difference between walking at, I'm not sure if you use kilometers or miles per hour, but
Kilometer, usually we use
kilometers. Okay, yeah, I put both up there. So if someone comes in and they are exhausted at walking at 3 kilometers an hour, if you're able to double that, then you're actually moving them from the purple line upwards. So you are increasing their cumulative survival rate by about 20%. If they can keep up with the basic activities of daily life, then again, they have now improved their chance of survival. So the more that we can improve your fitness, the better your prognosis is going to be. When I spoke about the rate pressure product, here is a graph to illustrate that. So what you've got is the rate pressure product graphed against the workload. So let's say someone is on an exercise bike and they're working harder and harder and harder. You would expect that their blood pressure goes up and you would expect that their heart rate goes up. So the blue person is someone who is untrained, or they've just had their heart event and they've started an exercise program with us. You can see that the incline here, when they hit their ischemic threshold, so the ischemic threshold is at the point where they start to get angina symptoms. We've worked out their rate pressure product, their blood pressure at that time multiplied by their heart rate. So they are only about 50% of the capacity before they hit that ischemic threshold and have symptoms. So let's say that they can exercise on a bike and they can do 25 watts before they start to feel chest pain. If you can improve their fitness and they now become this green line, their ischemic threshold is still at the same point. Their heart still has the same limitation, that when your blood pressure and heart rate reaches a certain point, they will get chest pain. However, by being fitter, they are able to do twice as much work now. So let's say they can now do 50 watts on that exercise bike. They are able to commute to and from work. They are able to get down to the shops before they get chest pain. Not because their heart is any better, but because their periphery and their muscles and their body is fitter. So you are, even if you're not able to change the person's heart, you are able to give them much greater benefits and push them more so that you can start exercising them and getting them a little bit there as well. Sorry, I'm just seeing the comment. I will come to those comments if you want. So one way of adjusting the rate pressure product is very simply this. If you look at one individual who is doing arm exercise versus lower limb or leg exercise, by using the upper body, you are increasing the rate pressure product. So by utilizing the lower limbs, the individual is able to do much greater amount of exercise and therefore get the many benefits of exercise compared to if they are only using their arm. So if you're thinking about a program, you might want to think about doing some squats rather than doing some bicep curls, for instance, just so that you can get more benefit without hitting that rate pressure product. The other people that you absolutely do not exercise train because the risk of an event outweighs the benefits are anyone with an active pericarditis or myocarditis. So these terms are that there is an inflammation of either the pericardium, which is the sac that lies outside of the heart, or the heart tissue itself, the myocardium. So if there's an inflammation in there, and we sometimes see this, there's been a lot of discussion about the impact of COVID on myocarditis. The inflammation of the virus can go into the heart, but an active pericarditis or an active myocarditis, that is a contraindication to exercise. You probably would feel that if it's you or if it's your patient, they are not feeling very good and they probably don't want to be exercising anyway. There is also severe aortic stenosis and also regurgitation, which is the valves aren't able to close adequately, so the blood flow goes in the opposite direction. It regurgitates into the chamber that it's just been ejected out of. So severe requiring surgery, valvular disorders also are a contraindication to exercise. So let's have a look at that a little bit more as well. So here you've got the information about a heart. I'm just going to move that across, sorry. Very slowly. There. Okay, so here we've got a heart. In the top right-hand corner, you are looking at the pressures in a normal heart versus a heart that has got severe valvular disease. And this is an aortic stenosis. So the valve isn't able to open up to allow the blood flow through. And what you'll see there is that within the normal heart, the left ventricular pressure during systole is about 120, and during diastole, it's 10. In the heart that has been working much harder because of that stenosis, so the blood flow isn't able to come out of it, each time that it contracts, it has to work almost twice as hard. So the systolic blood pressure generated within the left ventricle of these hearts with severe valvular disease is 200. Which is significant. It's a much higher rate than that of the normal heart. And like any muscle, if you are walking around all day long, carrying an extra 10 kilos in your arm and having to hold it up, you're going to have a big, strong muscle at the end of the day. If you do that every single day for every single month of every single year for a number of years, you're going to have one really, really large muscle. And that's what happens with a heart as well. The heart tissue hypertrophies. And so this is when I was speaking about the younger athletes that have events, their hearts, some have a genetic abnormality where they have a hypertrophy. So they have large, thick walls. And if you think about those large, thick walls like you're seeing up here, it's because you have to generate a lot more energy for every contraction. So what happens? First of all, you are stretching the internal heart tissue, which does make it susceptible to an electrical abnormality. Remember, inside of the myocardium is where you've got all of your specialized fibers that send the electrical current, which is what causes the heart to contract. So by distorting that, you are putting the person at higher risk of developing an arrhythmia so that they can go into that cardiac arrest. So there's a cardiac arrest where the heart stops electronically, and then there is a cardiac arrest, which is a myocardial infarction, where you have a heart attack because there's not enough oxygen supplied to go to it. The other thing that happens if your heart is nice and the walls are really, really thick is that you could think it needs a lot more oxygen to supply to it. So the oxygen demand of a thickened ventricle is much greater. So you have to be able to provide a lot more oxygen to keep it viable. The other thing that happens is, actually, we don't need to go there. Okay, so how do you know if your patient has got severe valvular disease? The number one thing that you want to do is have an image. So an echocardiogram, which is an ultrasound image of the heart. That is the diagnostic procedure that will show you whether there's any thickening or abnormalities of the heart tissue, but also how that valve is working. If you don't have an image that's available to you and a report, then you can also look at blood pressure. So blood pressure between your two arms. If the right arm systolic blood pressure is significantly different to the left arm, then that is a way of very sort of crudely diagnosing that they might have an aortic stenosis. The other one that you can look at is pulse pressure. So the pressure when you're taking the pulse, the difference between your systolic and your diastolic blood pressure. If that is different to what you would expect in a person who does not have high blood pressure, then it may also indicate that there's a regurgitation. So blood comes out into the aorta and it regurgitates back into the heart rather than coming out. So you've got a bigger difference in systolic and diastolic pulse pressure. So they're just some very easy ways. If you think that there's something going on and they say, oh, I might have a valve problem, to exclude that, you can do the blood pressure or you can get the imaging report. Then the considerations here are if they've got mild to moderate or moderate to severe valvular disease, then you avoid any high dynamic or static components. So that is where there's a breath hold, anything where you are asking them to hold on to a handlebar for an extended period of time, etc. If they are symptomatic and they have severe disease, then they need to have surgery before you exercise them. There is very few cases where exercising an individual who has symptomatic severe valvular disease is going to be safe enough to warrant the extra risk. Unfortunately, another thing, if you have a look at the size of that ventricle of the top right-hand corner, the aortic stenosis heart, these hearts are not very easy to resuscitate. So if you have to do CPR or if you have to do a defibrillator, it's going to be very difficult, unfortunately, to be able to successfully do that. So that is why we don't want to, or we want to just check that there isn't significant valvular disease before exercising. Then we have a few other things. So anyone recently had a heart attack, a myocardial infarction, and that's within the last 3 weeks. Anyone who's got new atrial fibrillation, and if you're not sure about that, then the next one will hopefully exclude that for you. So anyone whose heart rate at rest is higher than 120. So by definition, that's a tachycardia. And if there is not a reason for it, then you need to investigate that before exercising. Uncontrolled diabetes, acute fever or systemic illness, a recent clot or an embolism within the last month, or anything that's showing that they are just getting worse. There's a decline.
Sorry, Luke, just to interrupt you.
Yeah.
Just interrupt you for a moment. I will ask the host, Dr. Munir, probably to mute everyone, except for the Professor Naylor. Thank you.
Thank you.
Ade, also Ade, please mute because.
And while we're there, okay, so yeah, thank you. Exercise program are the same as the old term cardiac rehab. Sorry, Martha, I'm not sure what that question is anymore. If a sedentary person wants to reduce the risk of heart disease, how long the duration of the exercise, for example, easy walk 3 times a week. So that the more regular that you do it, the better it will be for the person. We talk about exercise snacks. So sorry, I'm deviating here, answering some of the questions. So I'm not sure if you can see the question, so I'll read it. If a sedentary person wants to reduce the risk of heart disease, how long the duration of the exercise, for example, easy walk 3 times a week. So the answer to that is if they are sedentary, then moving them to being regularly active is going to be your first goal. So I think at this stage, when they've gone from sedentary to wanting to do a little bit, it's more important that you do a little bit every day than that you do a certain amount of exercise. If you've excluded this list, which I'm leaving up here so you can memorize it while I talk. And then once they've been able to incorporate a little bit of exercise daily, you can start to build it up to the goal of 150 minutes a week as a minimum. We talk about exercise snacks. So just like we eat food, we can have small snacks. Any exercise of about 10 minutes of duration will be sufficient to give you some of the benefits as well. Okay, so thank you. So we'll go back to our when not to exercise. If you can exclude these things, then we can assume that the benefit of exercise is going to be much greater than the perceived risk, so we can exercise them. So there is just some easy questions, and I'll take you through those questions that you want to ask your patient before starting to exercise to make sure that you are not putting someone at undue risk. Okay. So we are evidence-based practitioners. We don't just want to go out and give everyone the same exercise program. And so to do that, you need to understand who your client is. What is their main pathology? So for example, if an individual has high blood pressure or hypertension, then you have to think about physiologically, what is the impact on the cardiovascular system? So hypertension, the higher that is, the more the heart has to work the left ventricle to eject the blood out into the systemic. So there's an increase in afterload. So then you could easily think for an individual with high blood pressure whose heart is working really hard, it might start looking like that severe aortic stenosis where it's nice and thick walls. You want to reduce the afterload, so you want to drop the blood pressure. So think of exercises now with a lower blood pressure and a higher heart rate. Going out for a walk, maybe doing some dancing or something that's more aerobic in nature would be a nice match for a person like that. But you can only start to prescribe the exercise once you understand what the pathology is. And then what are the physiological implications of that? So understanding what types of exercise increase your blood pressure, what type of exercise increase your heart rate, is it using different parts of the body, upper body versus lower body that we've seen. Cardiac patients, unfortunately, have a lot of medications as well. So you also then need to take into account their medication regime. Some medications are going to try to diminish the increase in heart rate and the increase in blood pressure during exercise. They can also put the patient at risk of having hypotension or a drop in blood pressure before and after exercise. And then finally, we're going to put it all there. Remember, we've got that seesaw where we're trying to juggle the benefits and the risks. So understand what are the acute risks of exercising this person and how do we mitigate those. So this is a screening sheet that we put together so that we can individualize the program, and it takes you through step by step. I'll send this through. There is a QR code at the bottom, which will take you to an online site where it actually asks you the questions. What is the primary pathology? Is this an ischemic patient? Is this an arrhythmic patient? Is this a valvular patient? And then it asks you for different pieces of evidence to show how severe that is. Because some people can have a mild heart attack and some people can have a serious heart attack. And that really just distinguishes the amount of myocardium that has been impacted by the myocardial infarction. Then it asks you some questions about how it's been treated, et cetera, et cetera. So that's available there, and you can print off at the end of this a summary of what your patient is doing and what some of the flags might be. It also asks about medications, et cetera, so that you can take all of those things into account. And then we talk about personalizing the prescription. So now that you understand who your patient is, have they got a higher risk than normal to exercise? And also, what are some of the other things that we need to understand? What kind of medications are they on, etc. The reason that we want to do this is because we want to personalize the program for that individual. So I put these pictures here. We've got a sports car versus a family sedan. Now, if I was to say that they are going to go down the freeway and do 150 kilometers an hour, then that wouldn't really be taxing the engine of this yellow sports car too much. This Lamborghini would probably be cruising along doing quite well. Whereas probably if you're putting the big family station wagon at 150 kilometers, it might be getting very close to its max. And that is the same with our patients. So we have to consider how fit they are. How much activity do they do? Do they do that at work? Do they do that at home? Do they have a regular exercise program? How much do they weigh? What gender are they? How severe are their symptoms? Are their conditions? And do they have anything else that we need to take into account? Like they've got myocarditis, or they might have just had open heart surgery. So by thinking about those things, it would be silly for us to say exercise prescription is that both of these cars are only going to do 30 kilometers an hour, because the yellow car is going to get nowhere near its maximum capacity and therefore could be exercising for 5 hours a day and still not be seeing any benefits. So those questions are also in that online system through the QR code. Now, I've also put together some what I call cheat sheets for my students. So when you know the type of person that you're working with, there are certain indications that you want to. So we've looked at ischemic heart disease. So ischemic heart disease is the insufficient blood supply to the heart tissue, the muscle of the heart, the myocardium. And it's usually caused by restriction or occlusion of the coronary arteries. So before you exercise these individuals, be sure that you know where the blockage is, how severe that blockage is, has it been dealt with? So has it been opened up? And what is the extent of damage to the heart? And then there are some recommendations in the middle there of the starting levels. And at the bottom, I've given you the information that we've already spoken about. So don't forget the rate pressure product. What is their blood pressure? There's a trade-off between blood pressure and heart rate. So if someone is exercising really, really fast heart rate, make sure that their blood pressure is lower. The one thing I want to say about this as well is your heart only gives oxygen or blood to the heart itself during diastole. So when the heart is relaxing, it fills the heart coronary arteries with blood. So the faster the heart rate, the less blood is going to go to the myocardium, and therefore the more susceptible you will be for ischemia. So maybe just think about trying to reduce the increase in heart rate and focus more on the blood pressure for the majority of patients. Then there's also a risk of arrhythmias, and if you are working with people that have got heart disease, make sure that they've got their medication on board. So GTN, glycerol trinitrate, needs to be on hand. So again, I can share all of these and you can have these sheets. We print them out, they look like that, and we have them in our clinic, and it just really helps guide you of what the risks would be in the profile of the patient that you're working with. Here's one for arrhythmias. It's got the common symptoms, what you need to be mindful of before you exercise that person. If they've got a device, the implantable cardioverter defibrillator, an ICD, which is the device that sits underneath the skin. It has electrodes that go into the heart itself. There are some precautions there as well. So I'm just going to show you these. We're not going to go through them all. There's also things we've spoken about, these valvular heart disease patients. So remember, there's a red traffic light before you begin exercising them. Make sure it's not severe, make sure it's not symptomatic. What are the symptoms? If they aren't, what can you do for the exercise program? So again, more than happy to share all of those so that you have that as a guide for your practice. Because I don't believe that there are many patients where the risk of exercise outweighs the benefit if you understand the risks. That's why I want to provide this for everyone who wants to work with cardiac patients, so that you know that you can safely exercise them. But the other aspect of this is that the individual with heart disease has got higher risk. So there are some things that we need them to understand. So alongside of giving them the best exercise program in the world, there is also a bit of education and counselling that needs to be taken into account. So the first one there is, are they aware of their abnormal signs and symptoms? What does it feel like that your heart disease is getting worse? What does angina feel like? What does it feel like at rest? What does it feel like at exercise for that person? Number of cardiac patients that I've worked with who've all had ischemic heart disease, they've had quite a serious, massive heart attack, and you ask them if they had any chest pain and they say no. They did not know that they were having a heart attack because they didn't have that classic pain down the arm, like Hollywood tells us a heart attack feels like. So what are their symptoms? Are there any signs of exercise intolerance, so that they're more short of breath than usual? They're feeling dizziness. What does it feel like for them to know that this is a non-normal response to exercise? How do they monitor how hard they are working? So the guidelines say that we want the person to be working moderate, or they want to be working towards vigorous exercise. You're not going to be standing next to your patient all the time. So can they monitor their heart rate, or can they estimate how hard that they are working to make sure that they are not pushing too hard? Also very important, especially, unfortunately, I'm going to be a bit sexist here, for the younger men who've got heart disease, the importance of compliance to the prescribed exercise program. And it's probably not just younger men, it's probably healthier individuals. I would be a horrible patient if you told me that from now on I can only exercise moderately. I would be like, moderate? How about if I do a couple of sprints? Would that be moderate? So really understanding that the exercise limits that they've been given are there for safety. You don't want to get them into that ischemic threshold, because if their heart rate and blood pressure gets too high, not only may they get angina, unresolved angina is a myocardial infarction, and that's another heart event. The patient also has to have a fairly okay understanding about the medications, that their medications might interact with the exercise. So a warm up and a cool down will be very, very important. If they don't take their medications that day, their heart is no longer being protected, so they shouldn't exercise. And then the other information that will be very helpful for your patient so that they get more familiar and confident with exercise is that they understand what has happened to them. So do they understand the procedure that they had? Did they have surgery? Do they understand what the underlying pathology was? And also, what are their limitations? And are those limitations always there? Or are those limitations there until something else changes? So they are the things that we talk about before we start exercising an individual. Every day, when a cardiac patient comes in, we assess their clinical status. And that is because the symptoms of heart disease can change very, very quickly. So yesterday you were okay, today you are not. So each and every single time the person comes in, we ask, have you had any chest discomfort, angina, heaviness in the chest, etc. And I've got down there in gold, the clinical presentations can vary greatly because it does. One person might say that it's a squeezing, another person might say it's a heaviness. So you need to understand for that patient, what does their angina feel like? Because if you say, have you had any chest pain? They'll say no. But if you say, have you had chest heaviness? They might say yes, which is for us clinically the same. Dyspnea is the shortness of breath. Have you had any lightheadedness, any palpitations? Have you been feeling more fatigued or weak, or that when you do your normal exercise, it is harder than usual, or that you've had to have extra sleeps during the day? Cold and clammy skin, any stomach upsets, or generally feeling unwell. So we just run them very quickly through all of those questions to make sure, even if they're okay to start and be exercising with us, that today they are okay to be exercising with us. And I also send my patients home with this list. So this list here is 9 or 10 easy questions. Have you been feeling any chest pain? And if the answer to any of those is yes or more than usual, then maybe it's not the best, or we need to modify your exercise program. So they then have the number for our clinic and they can phone up and say, actually today, I'm feeling more tired. I feel really exhausted. Is it okay? Should I be exercising today? Yes or no? So we send this home with our patients as well. So let's have a look at some scenarios now. On the day, so my patient, I've screened them, they're fine, and they've come in to exercise. Remember that list that I left up before? The big no-nos when you do not exercise them? You should recognize this list here. So a new onset of atrial fibrillation, a resting heart rate that is over 120 beats per minute, any acute fever or systemic illness, their glands are up, they're feeling that they've got a cold or a flu, a recent emboli, so a thrombus that's gone off, or a decline in clinical status. Okay, so the considerations here. If you have a resting heart rate, the person comes in, I say the two easiest things that we can all do, whether we are a medical practitioner or not, is blood pressure and heart rate. And I don't mean heart rate, you put on an automatic blood pressure cuff and it tells you what the heart rate is there. I actually mean putting your fingers on the person and feeling their pulse. Because we don't just want to know the rate, the heart rate, but we also want to know how regular or irregular it is. Remember, if a person has got severe aortic regurgitation, you can actually feel that pulse pressure, which the machine won't be able to tell you if you've got an automatic blood pressure cuff. So it takes 15 seconds to get a pulse, or 10 seconds to get a pulse by feeling the individual. So I urge you all to go back to doing that. So resting heart rate, if it's above 100 beats per minute, or if it feels irregular, then you investigate that. You do not exercise that person unless you know why. The likelihood is that either they're stressed, they've run in, so you can rest them, take it again and it's dropped down, or if it's over 100 beats per minute and it's irregular, it's probably going to be atrial fibrillation. About 80% of people that are over the age of 60 or 65 are in atrial fibrillation. If that has not been treated medically, then you should not exercise them. And then blood pressure is the other thing. Is it too high? And by too high, is it over 200 millimeters systolic or 110 for diastolic? Or is it too low? Do they have symptoms? Or even, is it different from their normal blood pressure? So if my normal blood pressure is 100 on 70, and today I come in and it's 120 on 80, that's a normal blood pressure, is it not? Well, yes, but not for me. So for me, we need to understand what has happened. Did I maybe forget my medications? Or maybe I'm starting to have worsening of my heart disease. So just keeping a record of the normal blood pressure and the normal heart rate gives you so much information. And then asking a couple of questions. Are you feeling well? And has anything changed since last time I saw you? Now, I told you earlier that there was guidelines, and those guidelines use a maximal response to exercise. But also the difficulty with being a practitioner, and as a research practitioner, I fully understand this, is the research doesn't always translate into clinical practice. So how do we know if our patient is exercising and they have a normal response? So we want maximum heart rate, 60 to 85% of their maximum heart rate. If you don't have maximum heart rate, what do? There are some really crude mathematical models that we can use. 220 minus your age should give you your maximum heart rate. But we know that that is pretty inaccurate. So the more accurate version that I've come across is 206.9 minus 2/3 of your age as your maximum heart rate. But that may or may not give you an indication. So the other thing that's really, really helpful is the RPE. So if you're familiar with the Borg scale, it asks you to rate how hard you feel that you're exerting yourself, and it goes from 6 to 20. Now, many people don't realize that the reason it goes from 6 to 20 is exactly that this is supposed to estimate how hard you're working via your heart rate. So if you say that you're sitting around resting, doing absolutely no exertion at the moment, that's a 6. Maximal exercise is 20. Multiply those numbers by 10 and you should have the heart rate of that individual. Resting young person heart rate should be 60, maximal heart rate 220 minus 20, 200 beats per minute. So if you don't know all of those things, you ask the person to rate how hard they're working. If I say I'm at between 11 and 12, then my heart rate should be somewhere between 110 and 120 beats per minute. Super easy. You don't even need to put your fingers on their pulse to figure that out. The other really good test for heart rate response is the talk test. Is the person able to have a full sentence? Are they able to say a couple of words? That will tell you the intensity of their exercise. But the things to be careful of and to look into further when it comes to heart rate monitoring are, if your heart rate drops with exercise, if the exercise is getting harder and the heart rate is not going up or it's starting to drop, then that probably indicates that the heart is no longer able to supply the oxygen and the blood to the rest of the body to keep up. That's going to be bad for you and for the patient. Any change in rhythm, no matter what it is, if the person comes in and they're in atrial fibrillation and they start to exercise and they're in a bigeminy, or they're having more frequent ectopics, that's a change in rhythm, and that could potentially lead to something fatal. So if they notice that the rhythm is changing when they start to exercise, don't continue exercising them. And the other one is any symptoms reported by the patient. Even if you've got their ECG on and you're not seeing any changes in ST segments or anything that you're expecting to see on the ECG, if the patient says, I'm feeling short of breath, if the patient says, I'm having chest pain, you need to investigate that before you continue to exercise them, even if there's no evidence electrically. And then finally, we spoke about that ischemic threshold. So wherever the limit is, that going past here is where you're going to start inducing angina, etc. Take about 10 beats per minute off that. So really easy thing that we do is, thank you, we do a 6-minute walk test for people because, again, the math of that is easy. 6 minutes, multiply it by 10, gives you 1 hour. So however far the patient walks in 6 minutes, multiply that by 10, you will get how far they can walk per hour, or the speed on the treadmill. Whatever their heart rate is at that, take 10 off. So if their maximum heart rate during the 6-minute walk test when they started to get some symptoms is 160, then 150 beats per minute is their maximum exercise that you want to be using to make sure that you're not going to push them, and it gives you a little bit of safety around the ischemic threshold as well. So hopefully there are some simple and practical ways of knowing how to prescribe exercise without having to have a full university behind you to do the testing on each of your patients so that the guidelines make sense. One last thing when it comes to heart rate is that there is a thing called chronotropic incompetence. So that means the heart is no longer able to increase in rate. So the inability of the heart rate to get to at least 85% of the age predicted maximum, or that the heart rate doesn't increase as you would expect it to with exercise, then that is associated with an adverse prognosis. So if someone says to you, look, my heart rate never gets up above 130, no matter how much I push myself, or you are starting to exercise them and you notice that their heart rate isn't getting much above 120 or 130 or whatever, that might be associated with a poor prognosis. And there might be something that needs to be investigated if it's not already known. The other thing with a chronotropic incompetence, so the heart rate isn't being able to increase with exercise, is an ICD. So the ICDs have got amazing technology on them, and they can test, they can sense whether or not the person is moving. So there is a pedometer inside of those, and it looks at whether you're moving, as well as a heart rate monitor. And there's these amazing algorithms which tell the device when to shock and when not to. So you need to know the upper limit of that. The device will say any heart rate over, we usually put them really high, 200 beats per minute is where we think it's a ventricular tachycardia, and the program has been programmed, the device has been programmed to give off a shock. So then I would never let my patient get to a heart rate of over 190 beats per minute, because it could trigger that algorithm. There are also times where they have the ICD and it's not sensitive enough, especially if they're on a sedentary bike or in a gym setting, where the device doesn't know that they are trying to exercise and it's just seeing heart rate going up and up and up and up. So it tries to pace it to get it lower. And so therefore, the first sign is probably, you can imagine, you're trying to exercise and your heart rate is sitting at 60 beats per minute. You're going to feel dizzy. You're going to have shortness of breath, and that's what the patient might experience as well. So if they've got that device in and they're getting symptoms, you might want to go back and look at what the threshold for the defibrillator is. There's also a warning that I've put here as well, that magnetic or electrical fields might interact and change the settings. And we've noticed now that the newer iPhones, if you put those in your pocket over the ICD, can actually deactivate. It works like a magnet and it turns off the device settings. So just be mindful of that as well, that you're not using polar heart rate monitors or bioimpedance to get body composition, etc. if they've got a device. If you're not sure, probably better to investigate it or not to do it before going ahead. All right, I feel like I've been talking a lot. I'll give you a little pause there.
Yes, I think we need a break.
Otherwise, I'm happy to keep going. Are there any questions?
I think there are some questions that is still not answered yet.
Oh, okay.
In the chat box from Martha and also from Kashmita. I believe from Martha first, because it's really basic.
So it's referred to the exercise program showed, the same as the old term cardiac rehab. So cardiac rehabilitation is a multidisciplinary thing, which involves nursing, it involves exercise, it involves changing or modifying risk factors. So giving up smoking, changing your diet and all of those. More and more exercise-based cardiac rehab has become the goal that we're trying to do. So not just are we exercising our patients, but it's part of a multidisciplinary team. And all of the cardiac rehab is about trying to modify risk factors. and have exercise as part of that program. Okay, there's a question from Cash as well here about vitamin D. Swimmer and recommended to consume vitamin D. There is a bit of evidence that's emerging about heart health and vitamin D, but generally I would say, and this is very, very generalistic, as you know, you might be that Ferrari or the Lamborghini, and I'm talking about the car, the station wagon, but as a general rule of thumb, if you are not sufficient in the vitamin, then supplementation will not have a benefit. So if you have low vitamin D levels, then it's important to supplement to increase those so that they become normal. But your body works really, really tightly to regulate. We have homeostasis where there is a normal amount. If you are at that normal amount and you're supplementing and taking more vitamin D or vitamin C or whatever it happens to be, your body's quite efficient at getting rid of that. So as general, I would say if you have a lack, then it will help. But if you are at normal physiological levels, I'm not sure if I would suggest that it would help. Yeah.
And lastly, probably from Miko, you answered it already, but probably you mentioned that frequent is quite important for people, sedentary people, to start with the exercise continuously. But probably, do you have any target? What is the minimum target of the exercise that we should do every day for probably prevent the cardiac event? Yeah.
So we know that the guidelines say 150 minutes per week. And also we know that if you do in excess of 150 minutes per week, you are getting a smaller improvement. So it's an exponential curve, and the benefit is the greatest at 150, and then you still have a little bit more benefit as you keep going and doing more. But the majority of people, if you are just moving them from nothing to 150 minutes, will have the greatest improvement. That said, there have been a lot of studies that have now come out from the group in Texas, and they are really looking at sort of what's the minimal amount of exercise that you can do. And you may have heard of high interval intensity exercise training, where people are saying up to 30 seconds is enough to get the benefits. However, I say when you're only doing 30 seconds of exercise, the intensity of that has to be so high that if you're moving someone from nothing to that, you're actually increasing the likelihood of having an event. So until they become a regular exerciser, and they've been doing that for about, I don't know, at least 6 weeks, I wouldn't want to start playing with the intensity.
Okay. All right.
So then I would be saying a 10-minute minimum a day would be ideal.
Okay. Just one more question for me, because you mentioned a lot about the ischemic threshold and the RPP. Yeah. For the cardiac patient itself, how do you measure the ischemic threshold for the cardiac patient?
Okay. So any exercise that, so the American College of Sports Medicine has an equation where you can estimate the workload of any activity that you're doing. So you can put in there the mode of exercise, whether you're walking, whether you're walking upstairs, whether you are cycling, whatever your activity, and it'll tell you roughly what it is. So if you have no data and no means of measuring this, and you're not wanting to put your patient through a stress test, I would ask, do you get any chest pain? And if they say, yes, I get chest pain, let's say, when is it that you get chest pain? And they say, every time I walk up the stairs to get to my apartment, I will get chest pain. Okay, how many stairs have you got? Are they roughly this big or that big? Like, what's the size of the step? And then you can figure out from the American College of Sports Medicine calculation roughly how many METs that is. So what the VO2 is of that. And then working from there, you can also ask them, how hard does it feel when you're walking up those stairs? What's your RPE? And that'll give you the heart rate. So then you've got your heart rate and you've got your oxygen uptake or the intensity of the exercise, and look at what their blood pressure is when they're doing that. And that's your rate pressure product. If you don't want to do all of that maths, and it sounds very complicated, but there are websites where you can actually enter in, 20 minutes of exercise and it's this intensity, et cetera, et cetera. We use a 6-minute walk test. So a 6-minute walk test is easy. All you need is 30 meters of flat surface and a stopwatch heart rate monitor, and I would say blood pressure as well. And then you walk the person, and if they get any symptoms, then that is your rate pressure product right there, the heart rate and the blood pressure at that time. And that's simple enough. Yeah.
But in clinic, you do the stress test, right? For measuring the...
We actually don't. The guidelines recommend that everyone has a stress test. But if your healthcare system is anything like our healthcare system, to get someone booked in for a stress test would take at least 6 weeks, if not a lot longer. Every week that you delay starting an exercise program with a cardiac patient, we know sets them back by 1 month. So if you're waiting 6 weeks, that's 6 months that we've lost the ability to give them benefits. And also the longer you wait, the harder it is for the person to find time to put it in. There's that teachable moment just after you've had a heart event that you are more likely to come back and to make lifestyle changes, including take up exercise. So we only, in our clinic, do a stress test on patients to list them for cardiac transplant. They are the only patients that will have a VO2 in a stress test. So the majority of our patients come raw.
Okay, all right. Thank you.
Which is my frustration about us researchers writing these guidelines.
Yeah.
And why I'm hoping to share this with everyone as well. Yeah.
Okay, thanks, Liv. Yeah.
Not a problem. All right, so this is also some signs or symptoms. If any of these things happen when you are exercising, then you need to stop. So if there is a new onset of angina or angina-like symptoms, you stop. If the blood pressure drops as the exercise continues or gets harder, you stop. If the blood pressure goes lower than it was when they were resting, you definitely stop. Otherwise, that person's probably going to be lying on the floor soon. On blood pressure as well, if their blood pressure is too high, and this is really, really high, 250 millimeters of mercury, it's almost a medical emergency in the hospital, then you stop exercising. If there is any shortness of breath, any wheezing, any leg cramps or coordinations, that can indicate that there was a embolism which has gone in, a pulmonary embolism, the sudden onset of a leg cramp or claudican. It can be a DVT that's dislodged as well. Any signs that the cardiac output is no longer able to keep up with the demand, so that's poor perfusion, dizziness, confusion, looking pale, pallor, nauseated, cold and clammy skin, etc. Again, chronic tropic incompetence, which we've spoken about, the heart rate isn't able to increase, or just severe fatigue. Any of those are indications that something has gone wrong and you need to stop and investigate it further. So just remember those, even if it's a normal, healthy individual that's exercising, any of those are stop now, take me seriously, warning signs. So we've spoken about this. Now, I know that not everyone on this call is an exercise professional and will be doing the exercise prescription itself, but this is for all of us. So exercise as medicine is well established and there are many benefits, and we've already spoken about those this morning. However, as said in this fantastic paper, which I've taken from the British Journal of Sports Medicine, the art of knowledge transfer and implementation of exercise and physical activity remains poorly embedded in society, strategy, and clinical practice in all aspects of health. So I think there wouldn't be many people that would argue with you about the importance of exercise. Even the patients themselves understand that exercise is going to be really, really important. However, not everyone does it. So what you're seeing here is a diagram from Heart Failure Action. It was the largest exercise training study that we have seen And that's because exercise training studies are difficult. So in this study, 2,331 patients with stable heart failure were recruited, and they were either given usual care or half of them were given usual care with an aerobic exercise program. So this was going to be the big old trial that showed the benefits of exercise. What do you think we saw? Well, nothing. So when going back to actually looking at the exercise that was happening, this was a 12-month trial, and you can see here the amount of exercise that the individuals were doing who were in that exercise intervention. It went from 100 minutes, which again does not even meet the minimum criteria of 150 minutes per minute. And with time, it dropped down to about 80 minutes per week of exercise. The target for this group was to do 200 minutes of exercise per week. So 5 times a week, 40 minutes. This is one of the reasons that I say don't worry too much about the prescription of time, because we know even with the best funded clinical research trial, people were asked to do 5 times a week, 40 minutes each time, and they did half of that. Give it a little bit more time and they did even less than that. So when people say to you exercise isn't beneficial because the largest exercise training study that we've done in heart failure patients shows that there was no benefit, it's actually we don't yet know how to get the patients to buy into exercising regularly. So this is some of the adherence. This study was published in 2020, and it really looks at asking patients before they start exercising, what do you think will help you to continue exercising for 3 and 6 and 12 months from now? What is it that's going to be the biggest indicator? So of these individuals, they kind of all highlighted that their physical health would be the thing. So if they saw that there was improvement in their health, then they would continue to exercise. And the reason that they wanted to exercise was to improve their endurance, vitality, and energy. They wanted to be, as we said before, successfully aging. So in my mind, I'm thinking they want to have a goal of what I would be thinking of 5 METs of exercise capacity. If I can just get them to 5 METs, they're going to continue exercising for the rest of their life. They want to be able to walk, they want to complete their activities of daily life without becoming fatigued or short of breath. They want to regain the strength that they lost. They want to lose some weight, because we all want to lose some weight, and they want to feel better. But the interesting thing that this study then did was they followed the people up after the exercise intervention. So 6 months later, they then had a look at those people who maintained their exercise and those people who dropped out of the exercise program. And what you'll see here is that there are some significant differences between the group. Physical health was still the number one. But when you look at the things that differed between those that continued to successfully exercise versus those that dropped out of the exercise program, motivation and perseverance was rated more highly by those that continued to exercise. It was like 8, like the last thing that people predicted would help them if they didn't exercise. And people who dropped out of the exercise overemphasized the importance of knowledge. So they said, if you tell me what I should be doing, if you give me a goal to work towards and you help me monitor it, I will continue exercising. But this actually shows that if we can perhaps work more on the motivation and less on the knowledge, so it's not just about educating our patients, but it's actually how to build their determination, then we're going to have more and more people that are successfully continuing to exercise. So we looked at this and they kind of suggested that, all right, if people understand the health benefits, if you come to me and I say, look, you really need to exercise because it's going to make you live longer, you're going to be healthier, you're going to have independence, you're not going to come back to the hospital. If you exercise within the first 6 months of a cardiac event, you are 50% less likely to go back into the hospital for that year. That's a massive improvement. So this study looking at, it's called the COACH study, said, is it that people just don't understand how beneficial exercise is? We should spend more time telling you how important exercise is. 80% of all of the people who were exercising said they could tell us the benefits of exercise. So 8 out of every 10 people who are exercising said, I'm exercising, it's going to do this for my health, it's going to do this, it's going to do that. But even then, knowing the benefits of this, only half of them actually did what they were meant to do, which shows us that there is this big gap. It is not we just need to throw more education at people. It is not that we need to give them goals, etc. It comes down to this. So the group who successfully exercised told us this: motivation and perseverance. It is your basic determination. It is telling yourself, don't give up, keep trying. You'll have some good days, you'll have some you'll have bad days, you'll have good days. Only on your good days, that's when you do everything, do the best that you can, and that's okay. If you cannot do 20 minutes today, do 5, and that's okay. Because tomorrow you might feel better and you can do 30 minutes. But if you say, I'm not feeling good, I'm going to do nothing, then that becomes a massive barrier. The other thing that became important was the type of education that we give our patients. So the group that didn't continue exercising said motivation, our knowledge about exercising, educating us is going to be important. That actually was still important, but there was a slightly different slant. So these people who continue to exercise regularly said that the knowledge that they want to know that help them is how to overcome the misconceptions about how much exercise is necessary just to achieve positive outcomes. This message that exercise snacks, 5 or 10 minutes a day, is enough because that'll give you a benefit. It makes it achievable. Instead of saying you need to do an hour a day, how many of us are going to do an hour every single day of exercise? Even with the best of intention, with PhDs, with degrees, with all the rest of it, we know the benefits of exercise, right? But if I say to you, it doesn't matter, just doing a little bit is going to be enough. You don't need to do 3 hours a day. Half an hour a day is going to be enough to give you the benefits. In fact, half an hour a day is your ideal target that you would want 5 days a week, if you can. So by stemming the expectations and making it achievable was really, really important for this group. So this is our multidisciplinary team. This is me at the hospital. In the middle is our patient. And this patient also had a heart pump in. His heart recovered. And the thing that we're learning more and more is that we know less and less about the heart. So again, I said he had a pump in, and we probably would have only 5 years ago, maybe 10 years ago, done absolutely no exercise. He would have been lying in bed waiting to get a heart transplant. And then we started thinking, well, actually, we know that by not doing exercise is going to be bad for you. So can we exercise him? And so we started doing a little bit, and we monitored him, and the doctors were there and the nurses were there, and we were all really, really apprehensive. And then we realized he could do more, and he could do more, and he could do more. And eventually we realized he could do so much that his heart, even though he'd had a ischemic event and he'd had a myocardial infarction and we thought he wasn't able to improve, the heart function was getting so good that it was now not requiring that pump. So you'll notice here that the patient sitting on the bike doesn't have a bag anymore because the pump was actually taken out of his body, and his heart had recovered enough that he didn't need a heart transplant, which is the best solution for everyone, because a heart transplant, while it is great, actually just replaces one disease with another disease. There is a lifelong regime of medications. There are all sorts of complications, the increased risk of cancer, all sorts of things. So we want to avoid that as much as possible. The other reason that I put this up here is hopefully you can't tell who the nurses are, who the doctors are, who the exercise professionals are, who the dietitians are, et cetera, et cetera. And that becomes really, really important because we are a united multidisciplinary team, and translating it into practice, the strength of the physician's advice is significantly correlated with the likelihood of adopting increased physical activity. So if every time the patient comes to see a doctor, comes to see a nurse, comes to see an exercise professional, comes to see a dietitian, goes to their general practitioner, and they all say, have you been exercising? You know that it's important that you exercise, then they are more likely to continue. And we've just finished a study now where we've asked patients who are exercising regularly, why did they start exercising and what was it that was the most helpful? And the one thing that comes out again and again and again was, my doctor told me it was important. When I had my heart attack, my doctor told me it was important to exercise, and therefore I decided to start exercising. And when it got tough, I continued exercising. And then now I'm going to continue. By the time that they come to the exercise professional, if they haven't had that initial, this is really, really important from the doctor, it becomes a lot harder for us to work with them. We, of course, still can. So this is our patients. We ask them, number one, I don't have enough time. The reason I don't exercise is I don't have enough time, which to me tells me we're giving them the wrong message. We are saying you need to have an hour and a half in your day to exercise. How about finding within that 24 hours of your day, is there 10 minutes where you can go for a walk? Is there 15 minutes where instead of going on your scooter, you can ride a bicycle? Is there an opportunity where you can design into your day some exercise? Because then you don't need to put time aside to exercise. The other one, and this, complies with a lot of different things, I don't need it when I feel good. They think that exercise, like a medicine, you only need it until you feel better. When you start to feel better, you can stop exercising again. Lo and behold, they come back and they need to start again and again and again. It's like your medication. My cholesterol's better, so I came off the medication. Oh, my cholesterol's high again now. So it's that continual reinforcement. The other things was that they have a lack of motivation or accountability to exercise on their own. They're not sure about their capacity or what they could be doing. Another one that came up quite often was that it was difficult for them to get their head around that they now have heart disease. They identify as a healthy individual, and now they've had a heart attack. And so they're thinking, oh, okay, it takes me a while to get my head around that I have got heart disease. So they don't want to come to a hospital clinic because that's where you go when you're unwell. So how can we find ways that they can exercise with their friends, with other people in the community where they don't feel like a patient? We've done these amazing programs where we use football or soccer, and groups of guys come together and they all play together, and it helps with their adherence. There's some confusion about whether or not they should be exercising, and that's where you don't have the unified voice of that multidisciplinary team. And then mostly with the women, there was guilt. They felt guilty that they were prioritizing themselves and their health over time with their family and their family responsibilities. So then you'd be looking at things like, how do you and your children exercise together? How do you as a family do something that's going to be beneficial? So just finally, I wanted to go through some case studies with you. So these are real patients that you're going to meet. The first one is Christian, who is a 22-year-old male, and he was born with what's called Marfan syndrome. So if you're not aware of Marfan syndrome is a connective tissue disorder, and it does affect the heart and the greater vessels. You can spot a person with Marfan's because they are really tall and slender, and sometimes they have concave chest, like their chest hollows in. So he came through and at the age of 22 required a heart transplant because his Marfan's in his heart had affected it so greatly that he wasn't able to keep going. He had also had a Bentor's procedure, which is the replacement of the aortic valve and also the top part of the aorta. During his heart transplant, he had some complications. So he was in bed for 6 to 8 weeks with nothing, and he lost his muscle. So Christian, being tall and being a Marfan's patient, he was 6'3", so 190 something centimeters, and he weighed 50 kilos when he came to see us. He also now had a new heart, but not new blood vessels. So Marfan's affects the blood vessels. So we knew that we couldn't increase his blood pressure too much because then we could put those blood vessels at risk. So brand new heart that's working really well, lost most of his muscles, and you can see here how deconditioned he is. 50 kilos at 190 centimeters is very cachectic. But how do we exercise someone where we can't increase their blood pressure? He's had a heart transplant, so his heart rate is already high because you don't have the parasympathetics to slow down the heart. And he's really deconditioned. We had no idea. And then we came across this idea of eccentric contractions. So an eccentric contraction, and we've got a PhD student who's working on this now. A normal contraction is you shorten the muscle to generate force. And that's a concentric contraction. An eccentric contraction is that you're going to lengthen the muscle to generate force. So think about the difference of walking up a hill and walking down a hill. Walking down a hill is eccentric, walking up is concentric. The other thing you might know is if you're walking down a hill, your heart rate and your breathing doesn't get as heavy. It feels a lot easier to walk down the stairs or walk down or run down the hill than it is to go up the hill or up the side of the mountain. So eccentric exercise, you are 5 times stronger eccentrically than you are concentrically. Your heart rate and your blood pressure don't go up because you don't need to supply oxygen and blood to the muscle. So we thought maybe this could work for this guy. So this exercise bike here, and hopefully you see it, the pedals go around and his job is he's got to try to stop the pedals from going. So he's pushing into the pedal, which is an eccentric contraction of his quads and his hamstrings and his calves. And you can see here, he's kind of struggling a little bit, but he's pushing 300 watts. So if anyone's been on an exercise bike lately and tried to do 300 watts of exercise, it's quite difficult, especially if you weigh 50 kilos. So we were able to get him to do a lot higher wattage without increasing his heart rate or his blood pressure. And lo and behold, after only 3 weeks of this, Christian was able to develop enough muscle that he could then take part in all of the usual exercise program that we were wanting for him to be part of as well. And now he's back at school, he's finishing up his university degree, and he goes to the gym, his local gym, 3 or 4 times a week, and he's doing heavy weights, and he's twice the weight of what he was when he came in to see us. So he's been able to put on 50 kilos pretty much. Most of it is muscle, and putting muscle on when you've got Marfan's is particularly challenging. So he has done extraordinarily well because we were able to give him that very rapid increase in muscle strength early on. I'm going to skip this one and go to Sophie. So this is another example, just as a bit of background, childhood cancer. These are the incidents of childhood cancer in Australia. They are high. 20 out of every 100,000 children in Australia will have cancer, more likely to occur in the first 4 years of life. Fortunately, about 85% of all children born that have cancer will survive it for at least 5 years in Australia. And I think it's very much the same around the world. The problem, however, is that the very treatments that save them, so the chemotherapy, the radiotherapy, and the cancer itself, means that yes, they're surviving, but most of them have very complex disease pathology going forward. So 75% of all of the cancer survivors of childhood and adolescent cancer have at least one long-term serious condition. We also know that by having had cancer and surviving cancer as a child, you have very commonly an accelerated cardiovascular disease progress. At least half of the survivors will have heart injury. And the problem, unfortunately, is that you might be a child of 5 or 10 and you've survived cancer, but it is not until you're an adult, about 30 or 35, that we will actually be able to detect that there's been any damage to the heart. And so by the time that we've detected the heart damage in these children or young adults now, their 2-year mortality is 60%. So only 40% likelihood of surviving 2 years after we've been able to see the symptoms here. So we know that exercise is beneficial, and we know that we want to see it earlier. So these are some of the images that we use to determine whether or not there's been any damage to the heart. So cardiac MRI, also 3D and echocardiograms there to see whether there's any changes. And then we had this little girl come across our clinic. So this is Sophie, and at the time she's 8 years of age, sorry. She had a sarcoma in her leg, so bone cancer. And as you can see, she needed help even to push the pedals around one time. As she was going through the chemotherapy and as she was going through the radiotherapy, she survived, but her heart went into failure. So she had to be flown from Perth to Melbourne, which is a 5.5, 6 hour flight from Perth, where they could put in a artificial pump to keep her alive. Her heart was struggling so badly, as was her physical body, that she needed that just to stay alive. So then what happened? The first time she came in, she was really, really bored. She did 6 minutes and she said, oh, I'm tired. I can't keep doing much. And I thought, you know what? I see that you've got more in you. So we tried to make it a little bit fun. And by trying to make it a little bit more fun, we were able to stretch out the sessions. To make it even more fun, I asked her what she wanted to do, and she wanted to dance. So here she is with her bag, and she went from doing 6 minutes on a treadmill with frequent breaks to starting to dance and being able to do that. As her program progressed, we added in a bit more strength, so we increased and did boxing. So we took this girl from doing 6 minutes of, oh, I'm tired, which I thought was actually a motivation issue, and this is her increase. So you can see very quickly there, she's now in the top percentile. And this is Sophie, young Sophie, no longer with a bag because she had a transplant. 8 days after having her heart transplant, because she was able to get the periphery and all the rest of her muscles and her body so strong, she was able to leave the hospital and come back home. So when you ask, is there anyone who cannot benefit from exercise? I'm going to say no, as long as you can get the exercise prescription right and motivate that person to continue with adherence. And that, I would like to say thank you very much. I'm just going to check the door because someone has been incessant.
Someone was
Sorry.
That's okay. Untuk yang mau bertanya mungkin bisa raise hand atau menulis di chat box. Kita masih punya waktu 10 menit untuk tanya jawab.
Okay. Can I 3 minutes? Yeah. Yes. Yeah. Oh no. Yes. Okay. Sure. Sorry. Sorry.
That's okay. Can we continue with the questions and discussion? Yeah, I think that's okay. If you can't speak English, then you can write in the chat box. Then I will translate to English. So there is one question from Jatmiko again. If you can read there in the chat box. So when giving prescriptions and blah 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 to patients with heart problem, is it possible to consider weight training program at lower limb outside of functional training? And how or what is your considerations to make those kind of decisions?
Okay. When giving prescription to patients with heart problems, it may be possible to consider weight training program. Yes. So actually, the way that we start our programs for our heart patients is, if you think the restriction here is their heart. So their heart can't increase the amount of cardiac output. So heart rate and blood pressure is going to be reduced. And therefore, the amount of cardiac output is going to be reduced as well. So we want to minimize the strain on the heart by maximize the benefit to the muscles. So often what we do is we only target small muscle groups. So instead of doing functional exercises like squats, like clean and press or anything like that, we isolate a muscle group. So let's say the quadriceps, and we only exercise the quadricep, because that means even with a limitation of the heart, you are able to get a benefit to the muscles. You can increase the muscle size, the strength, the mitochondria, and all sorts of different things, which is going to help them improve. So if you can recall that graph with the ischemic threshold, you've got the blue person and the green person, by giving them more peripheral benefit, they are able to do more exercise and get more benefits. So we often just start people with simple one leg kick or something like that with some weight on it, and then you can increase the weight that you're doing. You can also do things like one leg at a time, so unilateral training, which will reduce again that central or cardiac burden. So that is how we start our program, and then very quickly you're able to make gains And then from there, once the quadriceps have improved enough, you're able to go into a squat while not having a large increase in heart rate or a large increase in blood pressure, but small groups. So you're only using one muscle group, not multiple muscles at one time. And then as they progress, you can add in more functional exercises.
So Lou, probably some participants in here or some students in here doesn't understand what is the functional training. So probably can you explain a little bit more about the functional training?
Okay, sure. So functional exercise training is I'm not going to say a trend. It's a type of exercise where we say, look, there's no point in having big muscles and looking like a bodybuilder if those muscles can't help you do the things that you do every day. So functional exercises are things like learning how to get up off the floor and stand up. They are things like standing up out of a chair. They are things where you're using multiple segments of your body and combining them to replicate things that you would be doing in an everyday situation. So instead of just sitting there and exercising my little bicep, because what time of my day do I need to just exercise my bicep? I learn how to lift up my groceries and to do something which is functional in its essence.
Thank you. All right, so is there anyone want to ask again?
There's a hand up, Saskia, and there's also one, Ahmad.
Okay.
Yeah.
I think Ahmad want to ask, but he doesn't mention what is the question yet. Yeah, Saskia, if you want to ask.
Oh, okay. Thank you so much, Dr. Arga, for the opportunity that given to me. And first thing first, I'd like to say thank you very much to Professor Naylor for such a remarkably delivered lecture you have just given today. Actually, my question today is not specifically about cardiac event, but it's more about muscle strengthening or defining. Does that sound okay to you to answer?
Yeah.
Okay, so I've been wondering that is it fine or okay if we focus on certain muscle training we want to tone, despite of we instead of to move from one part to another part of the body. So I've stumbled upon different opinions from people on the internet saying that is it okay to for you to consistently do some part of training, like you do ab workout every day consistently until you get the results that you want, and another say that it's much better if you move from one part of the body training to another. For instance, maybe you do the upper part training on Monday, and then you move to another part on the next day. So I've been dying to know from you, especially who is expertise at exercise. So thank you.
Thank you for the question. So very interesting question. So the question is it better to target one muscle group every single day, or do you need to rest? So there are a few things that underlie the answer to that. One of them is that the way a muscle, so it depends on what your goal is, to be honest. But basically, the way that the muscle develops with exercise training is when you are lifting the weights, you are actually tearing the muscle fibers apart. Those muscle fibers then regenerate and they become larger, and that happens while you're sleeping and while you're resting. So we know that the guidelines always say that if you're exercise training a muscle group, you need to give them at least 24 hours of recovery. And the reason that you want to give them at least 24 hours of recovery is so that they can re-heal, which is what makes them stronger and larger. So if you're doing the same muscle to exhaustion and you're ripping it apart every single day, you're never giving it that time to heal. So it's not going to get the adaptations. And so that's one part of the answer. So exercise strength training, for most people, you want to have at least one day in between your muscle groups. So then what some very clever people have said is, okay, maybe then on Mondays I do my legs, and on Tuesdays I do my upper body, and on Wednesdays I do my back and shoulders, which means I can exercise train every single day. and still rest the muscle groups in between so that they're getting that. Now, if you're not replenishing with protein, then you are not going to be maximizing your muscle gains by doing that either. But the flip side of that is, and I don't know where I sit on this, to be very frank with you, Saskia, I'm sorry, it's not going to be yes or no for you. I'm going to give you things to consider.
Okay, it's okay.
So the flip side of that is, if I only do my, let's say my legs today, and I do 5 exercises, each of them to failure, then by the time I do my 3rd or my 4th exercise, my technique is going to be wrong. So I might be at higher risk of injury. Plus my muscles are already tired, so I'm not going to get as many benefits. So there are other people that are suggesting that you do multiple muscle groups every single day, which means every muscle group gets a good stimulus and a good workout. You do one thing for your legs and you do it well. You do one thing for your back and you do it well. You do one thing for your chest and you do it well. And then the next time you exercise, you do the same thing, but every muscle group gets a much larger benefit every time that you exercise because it's not already tired. So where you sit at that, and it depends on what your goals are. Why are you exercising? Are you exercising because you want hypertrophy? Is it because you want increased strength? Is it because you want extra power? Is it because you want aesthetically? All of those things would factor into your answer. And as I said, I don't know where I sit on it. I actually have just recently myself started doing multiple muscle groups per session rather than having the splits where it was upper body, lower body, etc. And I personally feel, for me, I can put more into each exercise muscle group than I can if I do 5 or 6. I'm already tired before it. Maybe as I'm a bit older, it helps me with injuries.
Okay,
Sorry,
thank you so much for the answer. Thank you so much for the answer, Professor.
So as I said, I'm happy for you to share this presentation as well, so that you have the QR code and things, and also I can give you access to these if you want to, so that you have got a little bit of some information when you're working with clients and things as well, to hopefully help you.
Sorry, Lu, I lost my connection. The internet is not stable. I believe that there are a lot of participants in here that still have questions, but unfortunately we are running out of time. Is it okay for one more questions? Okay, so this is Dr. Adrianta. So he asked you if there's a Q10 supplement for cardiac patients and exercise. What is your opinion about that?
So my first response is sometimes supplements interact with medications that are being prescribed to patients. So you have to make sure, and I mean, this is a question that we always go to the pharmacist to ask, is there any likelihood that the supplement will change the pharmacokinetics or the pharmacodynamics of the medications that the patient is on? Because you don't want to interfere with that. And some of, especially if they're on warfarin, which is a blood thinner, then it is very sensitive to many supplements. So yeah, coenzyme Q10, it's a popular one that people would be interested in taking. I don't know, again, it has been shown in some patients to reduce the severity of the symptoms, and they think it's got something to do with blood pressure, I believe. So Q10s can drop your blood pressure, I think, through vasodilation. But yeah, so first thing would be check that it doesn't respond to other medications that the person is already on. And then I don't know with Q10 actually whether it's the same as with a vitamin D, that if you have a deficiency, bringing it up to your normal physiological levels is going to be beneficial, or whether it's going to be beneficial in a supra or a higher than physiological dose as well. We haven't done a lot of research into the use of Q10, so I'm not very informed. But the rationale behind using it is that it's an antioxidant. So it helps with the blood vessels. So a antioxidant takes away, when the body, when you exercise, the shear stress on the blood vessel wall is detected by the endothelial receptors. Those endothelial receptors then create nitric oxide. The nitric oxide is released into the blood vessel, and it can either be used as an antioxidant or it can vasodilate and open up those blood vessels. So the theory here is that if you use Q10, you can spare the nitric oxide to become a vasodilator, to open up the blood pressure, to reduce, to open up the blood vessels, sorry, to reduce the blood pressure, rather than to be using it as a antioxidant. We have done other research looking at beetroot and other antioxidants and have found that the benefit of adding that to exercise has been quite small, and often we cannot detect it rigorously in research studies. So that's all that I know about that.
Okay, thank you so much, Lu. Unfortunately, that we are already running out of time. So it's a great pleasure for me and also for all the students in here, all the staff in here to meet you again, even though it is only online. Probably next year we can meet in person. And also,
I won't say no, Aga.
Really nice to see you again, and thank you so much for your great lectures today. I think there are a lot of things that we can learn from your lecture today, and hopefully we can meet again next year. And I'll see you again. Bye.
Thank you
Thank
very
you
much
so
for
much.
inviting me again. Thanks, everyone. See you.
So for the students in here, so we have about 5 minutes break before the next lecture from Dr. Wan Munsif. So if you want to have a break, go to the toilet and so on, we can meet again at 10 o'clock. Okay, see you. Oke, Bapak Ibu, kita punya waktu 5 menit untuk istirahat. Kita akan melanjutkan lecture-nya. Waktunya akan dimulai jam 10. Jadi monggo silakan kalau misalnya mau ke belakang sebentar ataupun ke makan sebentar. Dan mungkin teman-teman yang mau bertanya dalam bahasa Indonesia tidak apa-apa, silakan menulis di dalam chat box. Good morning, Dr. Munsif.
Good
Selamat pagi.
morning. How are you, Arga?
Yeah, good.
Good.
How are you in Kuala Lumpur? Oh,
Yeah.
not Kuala Lumpur ya, Bangli ya.
Yeah,
Bangli.
Bangi.
Yeah, Bangi.
But actually it's near from KL, as you know.
Yeah.
Yeah, around 40 minutes. So, Arga, how are you? I'm fine here. Thank you very much.
I'm also good, thank you.
So, you are in office?
Sorry?
You in office? You in the university now or at home?
Yeah. I'm in the university in Surabaya.
All right.
Yeah. So, Dr. Mas, if you don't mind, can you please give the lectures probably in Melayu or Bahasa?
Yes,
I think
sure.
it's more convenient for us in Indonesia.
Yeah, sure.
Yeah.
Actually, that is the first thing I would like to ask to all of you. Itu perkara yang pertama yang saya ingin tanyakan.
Yeah, I think it's okay. But there's, I think, one of students from Malaysia, because this is a joint lecture. So there's one student from Malaysia who cannot really speak Melayu or Bahasa.
Yeah.
So yeah, probably you can mix between Indonesian and English. But yeah, most of us is Indonesian. So probably it's more convenient for us if you can teach in Indonesia or Bahasa.
Right. Yeah, it's great. Nice to hear that, because I know that before this previous lecture, all of you was delivered in English languages.
Yeah.
Okay, no problem. Saya akan bercakap menggunakan bahasa Melayu lah. So saya rasa banyak yang lebih faham dan mudah untuk digarap ilmu itu.
Yeah.
Okay, no problem. Thank you.
Should we start now? You ready?
Yeah, I'm ready. It's up to you.
Terima kasih. Mungkin sebelum kita mulai, saya ingin memperkenalkan sedikit Dr. Munsif ya. Dr. Munsif adalah dosen, jadi sport lecturer dari Faculty of Education Universitas Kebangsaan Malaysia. Dan beliaunya ini concern dan fokus riset fokusnya itu adalah ke sport massage ya, dan juga pengaruhnya terhadap cortisol, if I'm not wrong ya, cortisol and also pre-competition anxiety.
Yes.
Malaysian athletes ya. So saya persilakan kepada Dr. Munsif untuk memberikan lecture-nya. Kita punya waktu kurang lebih sekitar 100 menit, 100 minutes. But if you want to have a break in between, just to answer the questions, so that's okay.
Okay, baik. Terima kasih kepada Dr. Arga. Assalamualaikum warahmatullahi taala wabarakatuh, and a very good morning. So, how are you today? How are you, everyone? So, I hope today we can have a two-way communication. So, semua okay ke? Semua sihat?
Sihat je, Alhamdulillah.
Alhamdulillah.
Alhamdulillah sihat.
Kalau okay, semua buat macam ni. Alright, so thank you. Jadi saya mohon izin, I would like to ask a courtesy from all of you that I would like to convey the knowledge and my experience in two language, which is Bahasa Melayu and English. So is it okay for you?
Okay je, boleh.
Alright, so thank you. Alright, so nama saya Wan Ahmad Munsif Wan Pa, atau boleh panggil saya Munsif. Saya merupakan pensyarah di Fakulti Pendidikan Universiti Kebangsaan Malaysia, atau lebih dikenali sebagai UKM lah. Baik, selain daripada tugas saya sebagai seorang pensyarah di Fakulti Pendidikan, ini intro sikit lah, kita boleh pergi secara formal and agak leisure. Saya sebenarnya adalah salah seorang individu yang masih aktif sebagai atlet, iaitu atlet tenis. Kalau di Indonesia kita panggil olahraga ya.
Iya betul. Kalau di sana sukan ya?
Ya, di sini saya panggil sukan lah. So jadi bila saya sebut sukan, you all kena faham olahraga lah. Okay, dan selain daripada itu, saya merupakan seorang jurulatih tenis di Universiti Kebangsaan Malaysia. Dan untuk makluman semua, apakah kaitan saya dengan aspek sports massage ini ataupun dikenali sebagai urutan sukan? Jadi pada peringkat penyelidikan saya di peringkat Doktor Falsafah ataupun PhD, jadi saya menggunakan sports massage ini sebagai intervensi dalam mengawal stres dan juga melihat implikasinya kepada keupayaan fizikal dan juga teknikal atlet tenis. Okay, but somehow saya akan menceritakanlah sedikit sebanyak tentang introduction ataupun pengenalan tentang sport massage, and then mungkin dalam kuliah ataupun dalam kelas ini mungkin ada yang dah pernah dengar, ada yang dah pernah tahu, ada yang sudah familiar dengan apa itu urutan sukan. Baik, sebelum saya pergi kepada introduction, semua tahu apa itu atlet? Do you know who is athlete? You can answer my question.
Tahu.
Okay. Who is athlete? Siapa athlete tu? So can I have answer? Maybe Miss Bahul Munir. I saw you.
Okay. In my opinion, an athlete is a person who physically active and involved in a certain sport.
All right. So thank you. So Miss Bahul, are you an athlete?
I'm not.
So is there any athlete in this class? If you don't mind, you can, kamu boleh mengaku kamu adalah atlet. Okay, no worries, no problem. Okay, so
Saya atlet tapi di depan layar aja.
tapi apa yang saya tahu, Dr. Arga adalah seorang atlet ya, atlet hoki. Itu apa yang saya tahulah. Jadi mungkin ada anak-anak murid ataupun pelajar-pelajar di sini juga adalah merupakan seorang atlet tetapi malu untuk mengaku. Tidak mengapa. Okay, so sebenarnya kalau melihat kepada definisi, urutan sukan adalah satu aktiviti manipulasi otot yang diaplikasikan kepada atlet, sama ada profesional ataupun tidak profesional. Namun begitu, sebenarnya urutan sukan ini boleh digunakan juga kepada non-atlet. Okay, but depends on their condition. But before that, I got my slide. So can I share my slide? Can I?
Yeah, sure.
So what is in your screen now?
That's a PowerPoint, but still not in the presentation view. So, yeah.
So, is it
All
clear?
good. Yeah.
Okay, all right. So thank you. All right. So before we move further, so basically, atlet ini adalah seorang individu, is a person who always yang selalu bekerja di sebalik tabir. Okay, instead of bekerja di hadapan. Kita ambil contoh sebagai pelari pecut. Okay, kita ambil sebagai contoh sebagai pelari pecut seperti Usain Bolt dan sebagainya. Mereka mampu berlari 100 meter dalam tempoh kurang daripada 10 saat. Dan apabila mereka berjaya berlari dan juga akhirnya menjuarai sesuatu kejohanan tersebut, mereka diberikan pelbagai imbuhan. Betul ya? Contoh macam di Indonesia, kalau Taufik Hidayat lah, kalau dalam badminton, Taufik Hidayat sangat famous lah kan, di Malaysia pun sangat famous. Jadi kita lihat, wah, bila mereka menang, mereka dapat hadiah cash, mereka dapat hadiah kereta, dapat hadiah rumah dan sebagainya. Namun begitu, di sebalik kejayaan mereka, kita perlu tahu bahawa terdapat banyak sangat pengorbanan mereka di sebalik tabir. Okey, yang pertama sekali, untuk menjadi atlet ataupun individu yang profesional dalam bidang sukan, yang pertama sekali adalah mereka perlu menjaga latihan mereka. Yang kedua adalah mereka perlu menjaga pemakanan mereka. Dan yang paling penting, the most important thing is they need to take care of their sleep amount. Okay? Jadi perkara-perkara ini sekiranya tidak dijaga dengan baik dan tidak diberi perhatian dengan sewajarnya, maka atlet ini mungkin berada dalam situasi yang fragile ataupun terancam. Sebab apa? Kalau kita lihat di mana-mana negara, Okey. Kita panggil bank of player, bilangan pemain. Contohlah, kalau Taufik Hidayat itu berada dalam keadaan yang tidak sihat, iaitu berlaku kecederaan terhadap beliau, maka ramai lagi atlet-atlet yang di bawahnya, junior dia ataupun yang hampir sama taraf dengan Taufik Hidayat yang mungkin boleh digantikan. Okey, sebab itu saya cakap atlet ini sangat fragile. Kalau dia mempunyai kecederaan, okey, dan kecederaan itu berlaku pada tahap yang tertinggi, misal kata Taufik Hidayat pada ketika itu adalah nombor 1 dunia, mungkin pada ketika itu, tetapi jika berlakunya kecederaan yang serius, maka masa hadapan beliau daripada cerah akan bertukar kepada agak malap. Okey, mungkin beliau sudah tidak dapat bertanding di peringkat kompetitif, mungkin beliau terpaksa rehat dalam jangka masa yang lama, atau beliau terpaksa terus withdraw ataupun berpencen daripada sukan yang diceburi. So ingat ya, apabila kita menjadi atlet ataupun saya bercerita dalam konteks atlet dulu, and then kita go for non-atlet. So bila kita menjadi seorang atlet, sebenarnya kehidupannya sangat-sangat terancam. So jadi you all boleh relatekan dengan injury dan juga ancaman yang akan diterima. So all of you are okay? Still okay? Alright, thank you. So this is my little background in a sports massage. So basically, as you all know, seperti yang anda tahu sekarang ni, saya adalah seorang ahli akademik dalam bidang sukan. But somehow before I went through to the academic life, actually pekerjaan saya adalah sports masseur full time. Okay, sekitar tahun 2015 hingga 2016. Kenapa dalam masa setahun saja? Okay, untuk makluman semua, saya mula menjadi dosen ataupun pensyarah sekitar 2016 pada bulan 8. Okay, but somehow before that, pada penghujung 2015, saya telah habis pengajian saya di peringkat masters. So, in between that particular period of time, I got a lot of time, plenty of time. So, I decided to become a sports masseur. So, in Malaysia, okay, in Malaysia is considered still a new area. Because why? Urutan sukan di Malaysia mula dikenali sejak tahun 1998. Okay, pada ketika itu Malaysia mula menganjurkan kejohanan sukan Commonwealth. Okay, dan pada ketika itu Malaysia mula mempraktikkan elemen-elemen sains sukan, dan pada tahun itu urutan sukan mula diperkenalkan. Okay, so pada tahun 1998 sebenarnya saya boleh consider saya ni sebagai seorang yang masih kecil. Okay, dan saya pun tidak tahu lagi tentang kewujudan urutan sukan. Dan pada tahun 2016 juga, 2015 dan juga 2016, saya telah banyak menerima jemputan daripada individu-individu perseorangan, kejohanan-kejohanan sukan seperti kejohanan maraton, seperti kejohanan tenis, seperti kejohanan berbasikal dan sebagainya. Jadi pada ketika itu saya menggilap saya punya kemahiran dalam urutan sukan, dan I believe how to get the certificate for the sports massage. Okay, firstly, based on my experience, saya merupakan seorang pelajar diploma bagi pengajian sukan. Di Malaysia ada satu universiti ni, nama dia Universiti Teknologi Mara. Dan dalam satu subjek itu dikenali sebagai sports injury subject. So, I've been introduced from this subject in term of sports massage. Masa itu sekitar tahun 2010. Tetapi pada tahun 2014, saya mula mengambil serius tentang perkara ini dan saya mula mengambil credential ataupun certificate from authorized organisation. Okay, dan pada ketika itu, pada tahun 2015 dan 16, saya menjadikan urutan sukan ini sebagai sumber pendapatan saya. Okay, so it is part of background of sports massage in myself. Okay, so now berbalik kepada soalan saya tadi. Jadi who is athlete? Okay. Athlete is a person who involved in a competitive activity guided by established rules. Jadi atlet ini merupakan individu yang menyertai dalam aktiviti sukan yang berlandaskan peraturan-peraturan yang telah ditetapkan. Okay, so atlet ini boleh terbahagi kepada profesional, separa profesional dan tidak profesional. Jadi walaupun mereka ini profesional ke, tidak profesional ke, separa profesional ke, as long as they are involved in sport, so they are considered as a sports person or athlete. Okay, alright. So, why athletes are so fragile? Okay, kenapa atlet ini sangat rapuh ataupun sangat mudah terancam? Okay, terdapat beberapa faktor, okay, yang mungkin menjurus kepada kecederaan sukan, okay, ataupun kecederaan ketika melakukan aktiviti fizikal. Yang pertama sekali adalah berkaitan dengan overuse of muscle. Okay, berlaku lebihan penggunaan otot pada pergerakan-pergerakan tertentu. Yang kedua mungkin disebabkan oleh faktor umur. Kemudian yang seterusnya adalah lakuan teknik yang kurang sesuai ketika melakukan aktiviti fizikal. Kemudian aspek memanaskan badan yang tidak mencukupi. Dan the second last is jenis sukan yang diceburi. Dan akhir sekali mungkin boleh disebabkan oleh faktor cuaca. Okay? Dan perkara-perkara ini boleh mendorong kepada kecederaan sukan. Meskipun seseorang itu adalah seorang atlet profesional ataupun tidak profesional, mereka ini memang sangat mudah terdedah kepada kecederaan. Okay? So I believe in this class, most of us have been experienced sports injury in our life. Okay, sebagai contoh, mungkin Dr. Arga sendiri pun pernah mengalami kecederaan ketika bersukan seperti ankle sprain, okay, seperti delay onset muscle soreness ketika bersenam dan sebagainya. Okay, so dekat sini ada tak yang bermain bola sepak? Kalau ada, tekan nombor 1. Kalau di Indonesia kita panggil apa? Bola sepak, bola sepak.
Sepak bola.
Sepak bola. Alamak. Terbalik.
Terbalik kita. Karena kan kalau bahasa Inggris kebalikannya ya.
Oh, sepak bola. So, Miss Bakul, are you a soccer player?
I'm not a soccer player.
James, Kevin, are you a soccer player? A football player?
Yes, I like soccer.
So you are striker, a defender?
Just for fun, not a sport.
All right, just for fun. So sometimes you become a striker, sometimes you become a defender, sometimes you become a goalkeeper. I don't know. Okay, so have you experienced a sports injury before this, James?
No, doctor.
Not really. So if you are not, kalau kamu belum ada pengalaman dalam kecederaan sukan, so probably you are one of the luckiest person on the earth. Okay, alright. So this is few factor. Okay, faktor-faktor yang mungkin boleh mendorong kepada kecederaan dalam sukan. Alright. So now we are focusing on the history. Okay, we're focusing on the history of the sports massage. So basically urutan sukan ini telah ditemui sekitar 3,000 tahun yang lalu. Sudah lama ya. Sudah lama. Okey. Ini bukan urutan, maafkan saya, bukan urutan sukan, urutan in general. So in general massage has been found 3,000 years ago. Okey, di negara seperti China, India dan juga Greece. Jadi kalau 3,000 tahun lalu satu jangka masa yang sangat lama lah But somehow during 1976 till 1839, sorry, ini typo. 18, this is typo, sorry. Forget about the year. Per Henry Ling have found, beliau merupakan founder kepada gaya urutan, yang dikenali sebagai Swedish style. So, at the early stage, Ling dia telah menciptakan teknik-teknik urutan yang tertentu to manage the sports injury, untuk menguruskan kecederaan sukan seperti sukan gimnastik dan juga sukan pedang di negara beliau. Okay, so kebanyakan negara di dunia ini has been endorsed the importance of the sports massage. So antara negara yang telah mengiktirafkan urutan sukan ini, mengiktirafkan kepentingan urutan sukan ini adalah seperti United Kingdom pada tahun 1990. Sekitar 32 tahun yang lalu, di mana Malaysia mula menerima urutan sukan ini secara serius sekitar tahun 1998. Namun begitu di Indonesia, saya belum menerima maklumat ataupun data tentang bila urutan sukan ini mula diperkenalkan di Indonesia. So mungkin barangkali pelajar-pelajar di dalam kelas ini mungkin boleh membuat sedikit kajian ataupun penyelidikan tentang sejarah urutan sukan di negara anda. Okay? Alright. Alright, so if we are focusing on the definition of the sports massage, kalau kita melihat kepada maklumat yang diberikan oleh Payne 2015, so urutan sukan ini secara asasnya dicipta untuk mencegah kecederaan berkaitan senaman ataupun sukan sahaja. Okay, alright. So sports massage can be implemented during, before, during, and after training and also tournament. Alright. Jadi urutan sukan ini sebenarnya dia menggunakan teknik-teknik tertentu, yang direka khas bagi tujuan untuk meningkatkan daya tahan dan juga performance, untuk mengurangkan kecederaan dan juga mempercepatkan tempoh pemulihan atau dikenali sebagai recovery. Dan saya pasti dalam konteks kelas ini, sebelum tu, Dr. Arga, may I know the background of the student? They are medical students?
So some of them, I think most of them are medical students, undergraduate medical students. So they are in the last semester before they graduate semester. So they are in semester 7. And then the other one is the students of the Master of Exercise and Sport Science. So yeah, I think they already a little bit familiar with the sport massage.
All right, that's great.
But I don't think I don't think so with the undergrad medical students, because we never teach about the sport massage before.
Okay, all right. So thank you for the information. So basically, in general, if you are medical students, so we believe after we perform medical surgical, so the patient sometimes need a little bit of time for their recovery stage. All right. So because after surgical procedure or operation, somehow mereka memerlukan masa, klien-klien ataupun pesakit-pesakit memerlukan tempoh untuk pemulihan. Okay, but somehow in sports massage, kita tidak mempraktikkan urutan sukan itu terus kepada individu yang baru menjalani pembedahan. Kerana mereka ini baru mungkin pada permukaan superficial tissue baru dijahit dan sebagainya, dan kalau kita mengimplementasikan apa-apa urutan mungkin akan menyebabkan kecederaan yang lebih serius. So we have to know the condition of our patient. Okay, alright. So next, actually kalau merujuk kepada Mechanic pada tahun 2014, urutan sukan ini dikenali sebagai complementary alternative medicine dan diaplikasikan kepada para atlet di luar sana. Okay, is a complementary alternative medicine di mana apabila mungkin atlet-atlet itu memperolehi kecederaan dan mungkin diberikan bantuan ergogenic aid seperti suplemen dan sebagainya, dan bagi mempercepatkan proses pemulihan tersebut, urutan sukan ini merupakan salah satu kaedah complementary alternative medicine bagi mempercepatkan pemulihan. Okay, next. Okay, seperti yang saya maklumkan tadi, menurut Thomas pada tahun 2008, sport massage is a mechanical manipulation, okay, manipulasi mechanical terhadap tubuh badan dengan tekanan berirama bagi tujuan meningkatkan tahap kesihatan dan juga kesejahteraan yang dikenali sebagai wellness. Okay, dan urutan sukan juga merupakan gabungan teknik-teknik urutan yang istimewa dan yang paling penting adalah bebas daripada penggunaan bahan yang berbahaya seperti dadah. Okay, is a free from drugs in order to help the athletes. Okay, dan juga individu yang aktif bagi mengekalkan atau mencapai prestasi puncak. Okay, so before I go further, is there any question that you all would like to ask? Kalau ada, nak tanya sekarang boleh, nak simpan kejap lagi pun boleh. Okay, tak ada masalah.
Dadah itu ergogenic aid. What is dadah?
Sorry?
Dadah, what is dadah?
Oh, okay, in Malay.
Ergogenic aid or doping?
Okay, dadah in English we call drugs.
Okay, yeah.
Okay, so I would like to convey to all of you that the sports massage intervention is free from drugs. Okay. So next, berdasarkan pembacaan literatur ataupun based on literature reading, so basically there are few benefit that sport massage can contribute. So specifically ada 3 komponen ataupun 3 perkara sebenarnya bila kita mengaplikasikan urutan sukan. Yang pertama sekali kita akan lihat kebaikan urutan sukan terhadap aspek fizikal. Kedua adalah aspek fisiologikal, dan akhir sekali yang ketiga adalah aspek psikologikal. Jadi apa peranan terhadap aspek fizikal dan juga fisiologikal menurut beberapa dapatan di sini ya. So urutan sukan telah dikenal pasti bagi memberi ketenangan dan juga melepaskan muscle tension ataupun ketegangan dan juga kesakitan pada bahagian otot. Okey. Jadi bahasa Indonesia rasanya otot samalah muscle lah kan. Okey. Jadi yang pertama sekali adalah berperanan bagi melepaskan ketegangan dan juga kesakitan pada bahagian otot. Seterusnya adalah berfungsi bagi mengurangkan ataupun menyingkirkan bahan seperti asid laktik di dalam tubuh badan kita. Seterusnya adalah bagi mengurangkan ketidakselesaan daripada DOMS, okay, mungkin daripada latihan yang berintensiti tinggi, perlawanan yang mungkin lama, sebab ada sesetengah sukan, okay, ada sesetengah sukan di mana tempoh perlawanannya berbeza-beza, berbeza-beza. Okey, contohnya dalam tenis dia tidak ada masa yang spesifik untuk menghabiskan perlawanan tersebut. Berbeza dengan perlawanan seperti bola sepak. Kalau bola sepak, kita telah diberikan masa selama 90 minit untuk menghabiskan perlawanan tersebut. Okey, jadi mungkin sukan-sukan yang mempunyai masa yang tidak tentu dan mungkin juga masa yang telah diberikan disebabkan oleh jangka masa yang mungkin panjang ini akan mendorong kepada delay onset muscle soreness. Dan yang paling senang ataupun mudah untuk kita merasai pengalaman delay onset muscle soreness ini adalah apabila kita melakukan latihan bebanan. Okey, saya yakin dan pasti 5 pelajar daripada Airlangga yang bersama dengan Dr. Shakila sekarang ini telah menjalani kelas seperti kelas latihan bebanan, kelas latihan circuit training, interval training dan sebagainya. Mereka mungkin didedahkan dengan aspek delay onset muscle soreness. Okey, so dia bila contohlah bila kita buat bicep curl, okey, kita angkat dumbbell kan. Contohlah James ni dia suka pergi ke gimnasium. Miss Bahul pun suka pergi ke gimnasium dan angkat beban pada bahagian tangan mereka mungkin dalam 20 kilogram. Saya tak tahu 20 kilogram itu sebenarnya agak berat. Dan apabila mungkin James dan Miss Bahul jarang melakukan latihan bebanan sedemikian dan bila mereka selesai melakukan, mereka merasakan sedikit sakit pada bahagian otot bicep. Okey, itu dikenali sebagai delay onset muscle soreness. So jelas ya. Okey, baik. Seterusnya, peranan bagi urutan sukan secara asasnya adalah bagi memperbaharui postur dan kelenturan kepada tahap yang lebih baik. So meaning that here, sports massage actually membantu dari segi aspek kalau dalam keupayaan fizikal kita kenali sebagai flexibility. Okay, flexibility component. So if you are sports person or non-sports person, flexibility is a very important thing in our life because kadar kelenturan yang baik akan menentukan proses sirkulasi ataupun blood circulation yang baik dalam diri individu seseorang. Okey, bila badan kita makin lentur, maka kita dijangkakan mempunyai pengaliran darah yang lebih baik, di mana pengaliran yang lebih baik dan juga lancar akan membawa nutrisi-nutrisi yang penting seperti oksigen, O2, membawa nutrisi-nutrisi makanan ke bahagian-bahagian otot dan sebagainya. Okey, itu antara beberapa faedah ataupun kebaikan urutan sukan terhadap aspek fizikal dan juga fisiologikal. Baik, seterusnya. Okey, jika kita lihat dalam aspek psychological, urutan sukan ini begitu signifikan dalam membantu persediaan mental atlet. Okey, sebab apa? Ini berdasarkan kajian yang dilaksanakan oleh pengkaji terdahulu dan juga saya sendiri sebagai researcher pada peringkat PhD, di mana saya telah dapat melihat perubahan yang signifikan dalam konteks hormon kortisol. Okey, maafkan saya di sini saya tak tulis, okey, tapi saya boleh ceritakan kepada anda semua. Jadi kamu semua tahu apa itu kortisol? So I think most of you know what is cortisol. Cortisol is our stress hormone produced from our body, okay, specifically from our adrenal cortex. Okay, adrenal cortex ini terletak pada bahagian sekitar kidney kita. Okay, dan pada bahagian itu badan kita merembeskan hormon kortisol apabila badan kita berada pada keadaan tertekan ataupun stres. Jadi berdasarkan kajian urutan sukan tersebut, berdasarkan intervensi urutan sukan tersebut, ia dapat membantu mengurangkan jumlah penghasilan kortisol dalam atlet tenis sebelum pertandingan? Okey, saya nak tanya kepada pelajar-pelajar semua, student-student semua, what do you feel? Apa yang anda rasakan sebelum ataupun sehari sebelum hari peperiksaan? What do you feel? Kalau anda tidak cukup mengkaji pelajaran, what do you feel before exam? Can you share with me? And Dr. Arga also. Can you share with us? Siapa boleh kongsi? What do you feel? Or how do you feel before exam? Siapa saya nak sebut? Akmal? Akmal Zidan?
Yes.
So, can you share with us? Boleh anda kongsikan kepada kami semua, jika sehari sebelum peperiksaan anda kurang membuat ulang kaji. So, what do you feel in terms of psychology and physiology?
Yang saya rasakan biasanya badan sakit semua.
Okay. Adakah anda berasa sedikit anxious, nervous?
Lebih ke nervous seperti itu.
Nervous maksudnya mungkin disebabkan oleh kurangnya mengulang kaji, anda mungkin mula untuk berasakan nervous. Betul ya?
Yeah, betul sekali.
Kebarangkalian untuk anda tidur pun mungkin terganggu, sukar untuk tidur, kan? Okey. Alright, terima kasih Akmal.
Yes, sama-sama.
So, itu adalah keadaan yang normal ya bagi seseorang manusia, di mana kita akan rasa sedikit tidak selesa ataupun kekok sekiranya kita tidak bersedia. Okey, sama juga dalam situasi sukan. Bila kita tidak berlatih dengan cukup dan esok kita akan lawan dengan mungkin oponen yang lebih bagus dari kita, kita akan mula risau. Okey, worry. So, the worry actually will enhance the production of cortisol in our body. So, salah satu cara untuk menstabilkan kortisol itu, mengurangkan kortisol itu adalah melalui urutan sukan ataupun sports massage. Alright. So, berdasarkan kajian yang telah dilaksanakan, memang terbukti mampu mengurangkan bilangan kortisol tersebut dalam tubuh badan kita. Alright. Jadi, sport massage ataupun urutan sukan ini boleh diaplikasikan bersama komponen ataupun kemahiran psikologi yang lain seperti self-talk, imagery, mental rehearsal dan sebagainya bagi menangani pre-competition anxiety. Dan selain daripada itu, ada juga teknik-teknik seperti PNF yang dikenali sebagai Proprio Neuromuscular Facilitation dan juga kita panggil PMR yang dikenali sebagai Progressive Muscle Relaxation. Dan apa yang saya sebut ini adalah beberapa komponen ya yang boleh kita buat pada masa yang sama membantu untuk memperbaiki kondisi fizikal, fisiologikal dan juga psikologikal. Okey. Jadi jelas ya urutan sukan ini merupakan satu perkara yang penting yang boleh kita pertimbangkan dalam kehidupan seharian kita sebagai atlet ataupun bukan atlet. Okey, so jika anda membuat kajian penyelidikan tentang urutan sukan, sebenarnya memang telah banyak dalam sumber-sumber data seperti Scopus, EBSCO, Google Scholar dan sebagainya. Jadi memang banyak kajian berkenaan dengan urutan sukan dan mungkin satu hari nanti pelajar-pelajar di Airlangga ni ada yang membuat kajian tentang urutan sukan. Okey, dan kalau buat kajian berkenaan dengan sport massage, mungkin kita boleh berjumpa, berbincang dan sebagainya lah. Okey. So, based on literature review lagi, okay, berdasarkan tinjauan literatur, jadi kebanyakan atlet telah bersetuju, more than 90% here. Okay, kalau kita tengok 93% sports person ataupun atlet telah bersetuju bahawa sport massage ini boleh dijadikan sebagai prevention terhadap injury ataupun pencegahan daripada kecederaan. Baik, 92% lagi atlet ini telah bersetuju bahawa urutan sukan mampu untuk menyelesaikan pelbagai isu yang berkaitan dengan otot seperti delay onset muscle soreness, seperti muscle knot, muscle cramp dan sebagainya. Dan yang ketiga adalah 90% atlet telah bersetuju bahawa sport massage ini dapat meningkatkan kualiti kehidupan mereka. Okey. Baik, secara teorinya, okey, kita sebagai manusia, tubuh badan kita mempunyai beberapa komponen seperti komponen tulang, lemak, otot dan sebagainya. Dan jika kita memberi fokus kepada urutan sukan ini memberi fokus kepada komponen otot. Dan kita harus tahu bahawa dalam tubuh manusia, ianya mengandungi kira-kira sebanyak 40% otot. Okey, badan kita, badan James, badan Saskia, Rizky, badan kita semua ada sebanyak 40% otot daripada keseluruhan berat badan kita. Okay, I think you know about this. Okay, alright. So, bagi mengaplikasikan urutan sukan ini, basically kita kena tahu, okay, you all need to know the anatomy, the position of our body muscles. Okay, jadi anda kena tahu apa itu, otot apa yang ada di dalam tubuh badan kita, bagaimana kedudukan muscle fiber di badan kita ataupun di atlet yang akan menerima urutan sukan tersebut. Okey, misal kata kalau kita lihat di sini, otot yang berada pada bahagian pectoralis major kita adalah berbentuk convergent. Okey. So pectoralis major ini berbentuk convergent muscle fiber dia. Okay, and then kalau kita lihat pada bahagian deltoid, okay, posterior deltoid ataupun ni, dia berbentuk multipinnate. Okay, kemudian kita lihat pada lower body, pada bahagian quadriceps, okay, otot tersebut adalah berbentuk bipinnate. Okay, pada bahagian bawah, pada bahagian kaki di bawah itu adalah berbentuk unipinnate. Okey, ini adalah bertentangan dengan otot gastrocnemius pada bahagian belakang. Okey, kemudian pada otot sartorius ini berbentuk parallel, okey, ataupun selanjar, dan pada bahagian bicep kita berbentuk fusiform. Okey, dan harus diingat pada tubuh badan kita juga ada otot yang berbentuk bulat ataupun circular. Okey, dan otot tersebut berada pada bahagian mulut kita. Dan pada satu bahagian lagi di tubuh badan kita yang berbentuk circular yang mungkin lebih jelas adalah pada bahagian tempat pembuangan air besar kita. Okey, di situ pun berbentuk circular. Okey. Baik. Jadi bila kita semua dah mengenali kedudukan otot ini, maka adalah lebih mudah untuk kita melakukan urutan sukan. Okey, adakah kita ingin membuat cross fiber ataupun parallel fiber apabila ingin kita melakukan urutan. Okey, dan itu adalah perkara yang penting. Ini adalah perkara yang penting. Kita perlu tahu kedudukan otot kita. Okey. Alright. Okay, so baik, dalam lecture saya ni juga, nanti di penghujung lecture ini saya akan kongsikan video tentang pengenalan dalam urutan sukan. Okey, sebab kalau sport massal ni sebenarnya kita kena ada face to face. So baru saya boleh tunjuk teknik itu, ini dan sebagainya. Tapi jangan risau, saya akan buat video demonstrasi sebentar lagi. Saya dah buat dan saya akan kongsikan. Baik, seterusnya beberapa perkara perlu dipertimbangkan, or there are a few things that you need to be consider before you give or you accept the sports massage services. Okay, kadang kita nampak urutan sukan ini adalah satu perkara yang mungkin memberikan ketenangan, keseronokan kepada atlet ataupun individu di luar sana. Tetapi kita harus ingat bila kita ingin memberi urutan sukan, okey, kita dan juga mungkin kita sebagai klien, pertama sekali adalah kita perlu memastikan keadaan tubuh badan kita adalah berada pada tahap yang terbaik. Yang pertama sekali, perkara yang paling mudah adalah berkaitan dengan suhu badan kita. Pastikan kita adalah bebas daripada masalah demam ataupun fever. Suhu badan kita tidak lebih daripada 37.5 degree Celsius. Dan selain daripada itu, of course kita kena pastikan diri kita bebas daripada masalah penyakit berjangkit seperti COVID-19 dan sebagainya. Okay? Tak kisahlah sama ada wabak COVID-19 itu ada pada kita sebagai sport masseur ataupun tak ada pada kita, ada pada klien kita. So kita kena clear. Both parties have to be clear about our health status. Apa yang saya sebut tadi. Bebas daripada simptom seperti selsema, batuk, sakit tekak. Elakkan daripada membuat urutan sukan. Okay? Please. Baik, seterusnya. Perkara yang perlu kita pertimbangkan semasa membuat urutan sukan ini adalah kita perlu lihat sama ada diri kita ataupun klien kita mempunyai kecederaan seperti open wound. Open wound ni semua tahulah, kalau dalam medikal luka. Okey, tak kisahlah luka tu kecil ke, besar ke, kemudian ada kudis ke, masalah kulit dan sebagainya antara A person and B person, so that bila kita membuat urutan sukan itu tidak berlaku transfusi bakteria, okey, pemindahan bakteria. So sebab kadang-kadang kita tak tahu, mungkin ada antara klien dan juga sport masseur itu ada masalah penyakit seperti TB. Kalau TB ni semua tahulah penyakit yang sangat berbahaya lah, boleh membawa maut. Okey, so elakkan ada masalah kesihatan seperti TB, kemudian ada luka, elakkan. Kemudian sekiranya atlet itu sangat baru mengalami kecederaan, okey, tidak sampai sejam ataupun 2 jam, kecederaan seperti muscle tear, muscle pull, ankle sprain, ankle ligament dan seterusnya, mereka juga mempunyai sejarah kecederaan seperti slip disc, tulang yang patah, tercucuk benda yang tajam dan juga bengkak. So kita kena consider. Okey, jangan terus membuat urutan, tanya dulu mereka situasi tubuh badan mereka. Okey, jelas? Kalau jelas sebab macam ni. Okey, thank you. Okey, seterusnya kita perlu juga pertimbangkan klien kita agar mereka ini bukan seseorang yang mempunyai masalah seperti penyakit kencing manis. Okey, boleh, tapi kita kena consider few things. Kemudian ada ketumbuhan yang tidak sepatutnya pada bahagian-bahagian badan. Kemudian mereka ini adalah bebas daripada masalah darah beku, okey, yang kronik. Dan apa yang paling penting, kita perlu consider kepada ibu mengandung, okey, pregnancy woman. Okey, urutan sukan atau apa-apa urutan kita tidak boleh sewenang-wenangnya buat kepada mereka yang mengandung, ibu mengandung. Okey, alright. So next, Jadi apa yang diperlukan untuk melakukan urutan sukan? Now we are focusing on the equipment. Okay, so yang pertama sekali kita perlu ada portable couch. Okay, portable couch kita kena ada yang ini ataupun dikenali sebagai portable massage bed, ataupun kita kenali sebagai splint. Okay, dan sekiranya kalau kita tak ada peralatan meja urut seperti ini, kita sebenarnya boleh menggunakan sleeping mat. Okay, sleeping mat, di mana kita ada sleeping mat and then kita hamparkan di bahagian lantai dan kita masih boleh melakukan urutan sukan. Tetapi harus diingat, bila kita melakukan urutan sukan di bahagian lantai menggunakan sleeping mat, ini dikuatiri akan menyebabkan spot muscle ataupun kita sebagai pemberi urutan akan mendapat kecederaan seperti back pain. Sebab apa? Dah lah kita kena duduk kat bawah lantai, and then kita kena bending bongkok lagi. So memang akan menjejaskan postur tubuh badan kita. Okey. Baik. Jadi apa yang kita perlu selenggara ataupun maintenance untuk portable couch ni? Okey. Jadi kita kena pastikan bahawa skru-skru yang terdapat pada meja ini adalah ketat, berada pada posisi yang sepatutnya dan tidak longgar. Pastikan tidak longgar, sebab kalau longgar mungkin akan menyebabkan meja itu boleh patah, dan bila patah tengah-tengah urut, tiba-tiba klien jatuh dan lagi teruk injury yang akan dihadapi oleh klien kita. So beware, ingat. Okey, seterusnya adalah massage oil, and then towel, and then kita ada kena ada timer lah. Okay, sebab kadang kita berpaksikan the repetition of massage punya stroke, but somehow ada yang terlebih dan juga terkurang masa. So kita kena aware, especially on the beginner sportsman world. Okay, kena ada timer. Baik, jadi kita fokus kepada aspek sebelum, semasa dan selepas urutan sukan. Apa yang kita kena buat? Apa yang kita kena tahu? Baik, sebelum memulakan urutan sukan, okay, tuan-tuan dan puan-puan, yang pertama sekali, you have to make sure our personal hygiene is in a good condition. Okay, so kebersihan diri kena jaga, pastikan kuku kita dipotong sebelum mengurut. Sebab kalau kuku kita panjang, mungkin akan menyebabkan contusion kepada superficial muscle, menyebabkan kesakitan, menyebabkan luka dan sebagainya. Dan kenapa kuku ini perlu dipastikan pendek? Kerana kita tak nak kuman-kuman ataupun bakteria yang tak sepatutnya berkumpul di bawah permukaan kuku kita. Okay? Beware, right? Alright, so kita kena pastikan bahawa macam saya mention tadi, tiada luka pada bahagian kulit. Okay, and then pastikan kesihatan kita dan juga klien kita adalah baik, membuat saringan terhadap atlet ataupun klien kita. So basically apa yang saya buat adalah pada permulaannya saya akan tanya James, so kamu ada sejarah kecederaan tak sebelum ni, in the past 3 days, in the past 2 days, 1 days, or in fact sebelum ni pernah mengalami kemalangan yang serius yang mungkin boleh menyebabkan patah dan sebagainya. So kita akan buat survey sebelum membuat urutan. Okey, jadi sekiranya anda ingin mengaplikasikan urutan sukan, kita perlu membuat sedikit survey terhadap klien kita, terutamanya pada mereka yang pertama kali mendapatkan urutan sukan. So clear, remember, ini adalah first step sebelum kita melakukan urutan sukan. Make sure all this thing is clear. Kemudian yang kedua adalah semasa. Okay? Fasa yang seterusnya adalah semasa kita mengaplikasikan urutan sukan. Kita kena pastikan bahawa kita berkomunikasi bersama atlet ataupun klien kita semasa mengaplikasikan urutan. tak semestinya sepanjang-panjang tu kita kena communicate. Kita perlu communicate bersama klien ataupun atlet kita apabila kita mengenakan tekanan or pressure to their muscles. Okay? Ingat, semasa mengenakan tekanan kita kena komunikasi. Sebab kadang-kadang komposisi otot Miss Bahul dan juga komposisi otot James Kevin adalah mungkin berbeza. Mungkin Miss Bahul adalah sedikit berisi, James adalah sedikit kurus. Jadi tekanan yang diperolehi mungkin berbeza-beza dan sebagai sport muscle perlu berkomunikasi dengan individu-individu ini. Seterusnya, kita perlu pastikan bahawa suhu ataupun temperature dan juga air ventilation di tempat yang kita aplikasikan urutan sukan ini adalah berada pada tahap yang baik. Pastikan bilik itu mempunyai pengudaraan yang baik, tidak semestinya mempunyai aircon, memadai dengan kipas, tetapi kalau ada air conditioner adalah lebih baik. Okey, dan pastikan bebas daripada pencemaran bau. So biasanya bila kita aplikasikan urutan sukan, kita kena elakkan bau-bau yang tidak menyenangkan, seperti bau sampah, bau hapak. In Indonesia, I don't know what word that are suitable to use. So elakkan bau-bau yang tidak menyenangkan. Okay. Dan bila kita mempunyai keadaan yang selesa seumpama ini, dia akan membantu sport muscle dan juga atlet untuk menerima khidmat ini dengan kadar yang optimum. Okey, baik. Selepas melakukan intervensi urutan sukan ataupun perkhidmatan urutan sukan, kita digalakkan untuk melakukan stretching ataupun regangan seperti PNF stretching, static stretching. Okay, kerana apa? Kerana urutan sukan ini memberi fokus kepada targeted muscle ataupun otot-otot yang spesifik, di mana fokus terhadap bahagian bukan otot seperti ligament, tendon adalah tidak diberi fokus ketika urutan sukan. Okay, so saya nak tanya you all, apa perbezaan antara tendon dan juga ligament? Siapa boleh share? Come on. What is the function of ligament and also tendon? So, who want to share? Saskia Rizky, you want to share with us?
Yes, doctor. So as far as I know, tendon is actually part of the muscle. So they are to attach to the bone. Meanwhile, ligament is like to group a muscle together properly, like the one in the wrist and also in the leg.
Okay, all right, then thank you. So anyone else want to try?
Excuse me, doctor.
You want to try?
Yeah.
Yeah. Am I right?
Yes. Yes, right, doctor.
Yeah.
Okay. As far as I know, ligament is a connective tissue that connects between bones, and tendon is connective tissue that connects between bone and muscle.
Okay, sorry, can you repeat?
Ligament is connective tissue that connects bones between bones, but tendon is between bone and muscle.
Yeah, that's right. Thank you.
You're welcome, doctor.
Okay, so jelas di sini kenapa kita mengaplikasikan, why we have to implement the stretching, whether it's a static stretching or proprior neuromuscular facilitation stretching towards the athlete or client, because in a sports massage, we are focused on the targeted muscles. Okay, all right, so clear. Okay, so there are a few things still we have to consider. It is the position of our sports masseur and also our client or athlete. Jadi atlet dan juga sports masseur perlu berada dalam keadaan yang selesa agar intervensi ataupun program urutan sukan yang diberikan dapat dilaksanakan pada tahap yang baik. Okey, misalnya kita lihat pada individu yang berbaju hitam ini, okey, beliau perlu berdiri dan membukakan kaki seluas bahu. Okey, apa akan jadi sekiranya kaki beliau dirapatkan tanpa sebarang jurang? Okey, siapa boleh bagi penjelasan? Okey, kenapa kaki perlu dibukakan instead of rapatkan kaki tersebut? So who wanna try? Why? Maybe Ahmad Nova Effendi would like to try? The yellow shirt. Okey, Ahmad Nova, barangkali mungkin ingin mencoba.
Ya, terima kasih dokter. Agar dorongan saat tekanan massage itu lebih sempurna, menurut saya gitu dokter.
Ya, betul sekali. Okey, so jadi kita perlu ingat ya, bila kita melakukan urutan sukan ini, ia melibatkan center of gravity. Okey, lagi besar kaki itu dibuka, maka lebih stabil graviti seseorang sport masseur itu dan dia boleh membuat body weight transfer ataupun pemindahan berat badan itu dengan sewajarnya. Sebab apa? Jika kita terlalu bergantung kepada bahagian tangan dan juga pergelangan tangan kita untuk diaplikasikan kepada otot klien kita, ini mungkin akan menyebabkan kecederaan kepada bahagian pergelangan tangan kita. Okay, so that's why our body position of sports masseur is very vital and very important. Okay, in order to give a significant impact to the client or athlete. Okay, jadi posisi atlet pula ataupun klien ini perlu berada sebegini. Okay, di mana kita akan memberi fokus kepada bahagian upper back and lower back body. Okay, alright. So next. Jadi ini adalah bahagian-bahagian yang sangat utama, okay, yang sangat penting bagi seseorang sports masseur. Okay, saya yakin dan pasti dalam kumpulan ini kita adalah individu yang dikurniakan anggota badan yang lengkap. Kita mempunyai dua tangan yang lengkap, kiri dan kanan. Jadi jika kita lihat pada gambar-gambar ini, seperti pada bahagian palmar surface, okay, pada permukaan tengah ini, base of thumb, ulnar border, the tip of finger and thumb, pada permukaan pads of finger and thumb, dan juga palmar surface of fingers and thumb is a very important part for sports masseur. Okay, ini adalah bahagian-bahagian yang perlu kita gunakan untuk mengaplikasikan urutan sukan. Okey, ada urutan sukan yang mungkin hanya memerlukan pada bahagian base of thumb, tip finger of a thumb dan juga ulnar border, seperti urutan ringing ataupun kneading dan juga dikenali sebagai patricage. Okey, nanti kita akan pergi apa itu yang nama-nama yang saya sebut tadi. So ingat ya, ini adalah bahagian tangan yang akan kita gunakan dalam mengaplikasikan urutan sukan. Okay, yeah. So now we are focus. Kita akan memberi fokus kepada 4 teknik utama dalam urutan sukan. Yang pertama sekali adalah effleurage, yang kedua adalah patricage, ketiga adalah friction, dan yang terakhir adalah tapotement. Okey, so jadi keempat-empat jenis urutan ini mempunyai fungsi dan peranan yang berbeza-beza. Begitu juga dengan gaya ataupun struknya yang tersendiri. Okey, mari kita lihat apa itu effleurage. Jadi effleurage ini adalah teknik ataupun gaya luncuran atau belayan yang panjang. Kalau dalam bahasa Inggeris dia kita namakan sebagai drifting. Okay, drifting, you know, wood drifting, kayu yang hanyut, apa-apa perkara yang hanyut, we call drifting. Okay, jadi teknik ini adalah teknik yang dikenali sebagai luncuran dan juga belayan. Okay, dan basically effleurage is the first technique that we implemented to our client or our athlete. Okay, jadi teknik ini juga merupakan teknik yang memberi ketenangan, relaxation dan juga mempromosikan pemulihan otot. Okay, sebenarnya semua teknik tadi mempercepatkan ataupun mempromosikan pemulihan otot. Baik, jadi terdapat 7 fungsi utama dalam teknik effleurage ini. Yang pertama sekali, ia adalah introduction kepada atlet. Ia adalah sentuhan yang pertama kepada atlet. Okey, yang kedua adalah membuatkan atlet itu berasa dalam keadaan yang selesa dahulu. Kemudian yang ketiga adalah memanaskan pada bahagian otot superficial, di mana otot superficial ini adalah otot yang paling hampir dengan kulit kita. Okay, that is what we call superficial muscle. Yang keempat adalah berperanan dalam menenangkan otot. Okay, to give the muscle relaxation. Yang kelima adalah untuk membenarkan sports masseur to identify, okay, the muscle condition of athlete. Sebab bila kita buat effleurage, kita akan menggunakan keseluruhan tapak tangan kita ini, okay, untuk merasakan ataupun untuk mengesan kedudukan otot yang mungkin berlaku sedikit perbezaan daripada permukaan yang lain yang kita boleh consider sebagai muscle knot, muscle spasm, atau yang lebih teruk kita kenali sebagai tumor lah. Okey, sebab kadang-kadang bila kita pakai baju kita tak dapat kesan benda-benda seperti tumor, bengkak dan sebagainya. Okey. Yang keenam, fungsi effleurage ini adalah to promote the blood circulation. Okey. Dan akhir sekali adalah untuk meregangkan otot kita. Okey, otot manusia. Baik, ini adalah rajah-rajah ataupun gambaran-gambaran urutan sukan yang menggunakan teknik effleurage. Okey, jadi effleurage, okey, ada yang tanya dekat saya, Doktor, kenapa kita memulakan urutan pada bahagian kaki dahulu? Kenapa kita tak mula pada bahagian upper back body? So, the justification is that kita hendak menolakkan kita nak menolak, bukan nak menolak, kita nak membantu meningkatkan peredaran darah daripada bahagian bawah badan ke atas, kerana pada bahagian atas mengandungi organ yang begitu penting, iaitu organ jantung. Okay, so that's why kita nak tolak semua darah yang mengandungi nutrisi-nutrisi dan juga oxygenated blood kepada jantung. Okay, sebab tu kita mula daripada bawah, tolak ke atas. Okay, daripada kaki naik ke atas badan. Okay, untuk teknik effleurage pada bahagian lower back body, iaitu pada bahagian gastrocnemius dan juga hamstring, kita akan mulakan pada bahagian hamstring dahulu dan slowly kita akan tolak kepada bahagian hamstring, gastrocnemius kepada hamstring. Okey, kita akan mulakan dalam keadaan yang perlahan, dalam tekanan yang rendah, dan slowly kita akan meningkatkan tekanan urutan sukan tersebut. Okey, dan bila kita dah daripada bawah tolak ke atas, bila kita nak reverse stroke itu, kita tarik ke belakang, dan pada masa yang sama bila kita tarik ke belakang, kita akan angkat otot tersebut sedikit tinggi. Okey, sedikit tinggi apabila kita ke bawah. Okey, daripada atas ke bawah tu kita angkat sikit masa. Jangan risau, saya akan tunjuk video sebentar lagi. Okey, baik, seterusnya. Bila kita selesai membuat urutan effleurage itu tadi di bahagian gastrocnemius dan juga hamstring, kita naik kepada bahagian atas iaitu latissimus dorsi dan juga trapezius. Okey, di mana kita akan menggunakan teknik kita akan menggunakan bahagian tangan yang sama, keseluruhan tapak tangan. Kita akan mula daripada lower back, okey, latissimus dorsi, dan kita akan terus naik ke bahagian trapezius, dan daripada bahagian trapezius turun ke bahagian latissimus dorsi, kita perlu melalui pada bahagian deltoid. Okey, ingat bila kita nak U-turn balik ke bahagian bawah itu, kita perlu melalui pada bahagian deltoid. Okay, so now the second technique is Petrich. Okay, macam yang saya maklumkan pada peringkat awal tadi, teknik ini juga dikenali sebagai kneading ataupun ringing. Jadi, teknik ini dikenali sebagai teknik menguli. Okey, menguli. Kita membuat bulatan pada bahagian otot yang di the muscle that we are targeted. Okay, so teknik ini menggunakan bahagian ulnar border, bahagian ibu jari kita, dan pada bahagian base of thumb. Okay, jadi pada teknik ini kita tidak menggunakan bahagian palmar surface. Dan objektif utama teknik ini adalah bagi meningkatkan pergerakan antara permukaan tisu, okay, meregangkan fiber otot, membantu untuk pertukaran cecair tisu, meningkatkan aliran vena dan juga limfa, dan sama juga untuk menenangkan otot. Okey, kedua-dua teknik effleurage dan juga Petrich tadi adalah berperanan untuk menenangkan otot. Okey, dia mempunyai beberapa peranan yang sama, tetapi ada juga peranan-peranan yang berbeza kerana teknik yang diaplikasikan juga adalah berbeza. So, ini adalah teknik, ilustrasi teknik yang digunakan untuk melakukan teknik ringing ataupun Petrich pada bahagian hamstring dan juga latissimus dorsi. Okey, so pergerakan dia, tangan kena dalam bentuk U ataupun V macam ni. Kalau you all boleh tengok skrin ataupun video saya, okey, dalam bentuk ini, dan kita akan tolak dia. Kita akan tolak dia. Kiri, kanan, kiri, kanan, kiri, kanan. And then pada penghujung dia, kita akan macam sedikit tutup macam ni. Bila tolak, dia macam ni. Okay? Okay? So, minta maaf, saya demo macam ni lah sebab kita tak ada face to face. Okay, so itu adalah salah satu cara dalam ringing ataupun kneading. So, satu lagi adalah kita boleh menggunakan pada bahagian bawah tangan kita sini. Okay, pada bahagian base of thumb, palmar surface and ulnar border pada bahagian bawah ni. Kita letak pada bahagian muscle, kita support dengan undominant hand kita, tangan kiri kita letak, dan kita buat bulatan. Itu adalah salah satu teknik kneading juga ataupun Petrich. Okey. Okey, seterusnya adalah teknik friction. Baik, teknik friction ini adalah menggunakan pada bahagian hujung jari kita. Dan kita menggunakan sedikit pergerakan kecil ataupun tekanan kecil yang dikenakan secara langsung pada bahagian otot. Okey, jadi kita akan menggunakan pada 3 hujung jari ini, okey. 1, 2, 3 pada bahagian hujung ini, dan kita akan letakkan undominant finger kita, undominant hand kita pada bahagian otot atlet ataupun individu. So kita letak direct pada otot yang mungkin mempunyai masalah seperti muscle knot, seperti mungkin ada sedikit muscle tension pada sesetengah otot, sebab kebiasaannya pada bahagian belakang badan kita, pada bahagian trapezius, you all pernah ada pengalaman tak bila tidur, bangun tidur sakit belakang? Nak toleh tak boleh. Kalau di Malaysia kami panggil salah tidur. Mungkin disebabkan bantal baru, bantal tak cukup tinggi dan sebagainya, and then bila kita tidur, kita bangun pagi, kenapa saya tak boleh toleh normal? Kan, kita sakit dekat belakang. Okay, so keadaan yang sebegitu, kita akan menggunakan teknik friction. Kita fokus direct kepada targeted muscle, kita menggunakan friction di mana kita akan meletakkan tekanan itu terus kepada otot yang bermasalah. Dan mungkin pada bahagian itu terdapatnya muscle knot yang berlaku. Okey, sebab apa? Kita boleh rasakan muscle knot ataupun muscle tension tersebut ketika kita melakukan teknik F-Lerach. Okey, baik. Jadi matlamat utama teknik ini adalah bagi mengasingkan antara lekatan fiber otot yang kompleks. Okey, kemudian memecahkan paru tisu, melebarkan saluran darah atau dikenali sebagai vasodilation, dan merangsang aliran darah ataupun blood circulation. Yang keempat adalah bagi merangsang proses penyembuhan, dan akhir sekali adalah untuk menyusun semula kedudukan tisu yang baru. Okey, clear Alright. So yang seterusnya, kita tengok ilustrasi. Ini adalah contoh yang mungkin berlaku pada individu seperti atlet ataupun bukan atlet yang mungkin mempunyai masalah selepas bangun tidur. Kita tengok dekat bahagian latissimus dorsi dan berhubung dengan trapezius. So pada bahagian ini mungkin mempunyai sedikit masalah ketika bangun tidur, dan kita akan mengaplikasikan teknik friction ini setelah melalui teknik F-Lerach dan juga PET research. Okey, ini adalah perkara yang ketiga kita boleh implementasikan kepada otot yang bermasalah. Okey. Okey. So untuk teknik yang keempat, tapotainment, sebenarnya ada dalam video saya. Okey, jadi saya akan kongsikan sedikit video saya, boleh Okey. Sebelum tu Dr. Arga, izinkan saya bertanya. Apa maksud materi? Materi ni nota.
Gimana?
Dekat chat box tu, mohon materi bisa di-share. Apa tu?
Oh, she wants to ask you, she ask you if you can share your
Slides.
PowerPoint presentation.
Oh, okay,
Yeah,
okay.
slide.
Sure, I will do. Okay, sekejap Okay, so before that, boleh kita test siapa yang ada dekat sini. Siapa yang ada dekat sini, semua tekan nombor 3 di ruangan chat. Okay, siapa yang ada dalam grup ni, buka bahagian chat, tekan nombor 3. So kita nak tengok, you all still here or not? Okay, semua tekan nombor 3.
Tik 3 di chat box ya.
Okay, banyak yang respon, banyak. Okay, alhamdulillah.
They're still alive ya.
Wow. Okay, thank you. So we share the video now. Okay, semuanya nampak apa ya di skrin? Video saya ya, YouTube.
Ya.
Okay, thank you. So, mari kita sama-sama saksikan. Ini adalah beberapa perkara asas ataupun teknik asas yang saya tunjuk ya. Okay, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Saya Munsif dan pada hari ini boleh dengar soundnya?
Bisa.
Kongsikan. dengan anda semua tentang teknik asas dalam urutan sukan atau lebih dikenali sebagai sport massage. Teknik asas yang pertama yang ingin saya kongsikan kepada anda adalah berkaitan dengan teknik yang bernama effleurage, di mana effleurage yang akan saya kongsikan kepada anda akan diberi fokus kepada bahagian kaki, iaitu pada bahagian gastrocnemius dan juga hamstring. Baik, pertama sekali saya akan letakkan minyak ini di bahagian tangan saya. Okey. Kita tidak letak direct terus kepada kaki dia, kita letak di bahagian tangan dulu. Kemudian kita ratakan pada bahagian tangan. Okey, kita letak pada bahagian kaki. Okey. Dan pada keadaan sebegini. Okey. Kita tolak dia daripada bawah, naik ke atas dan tarik ke bawah. Okey. Tolak ke atas. Okey, bila kita tarik, pastikan kita macam seolah-olah mengangkat bahagian otot ini ke atas. Okey, bawah dan naik. Turun. Okey. Bila kita nak naik ke atas, kita mula mengaplikasikan tekanan kepada otot. Okey. Tolak ke atas. Okey. Bila kita ke bawah, seolah-olah kita angkat otot ke atas. Dan sebolehnya kita communicate dengan klien kita atau atlet kita tentang tekanan yang digunakan ini adakah bersesuaian ataupun tidak dengan dia. Terlalu kuat? Tak? Okey, biasa ya. Okey. Okey. Baik. Itu adalah contoh stroke effleurage yang pertama. Yang kedua pula adalah pada bahagian yang sama, otot yang sama. Okey. Kita letakkan tangan kita pada bahagian otot ni, sebelah tangan naik ke atas dan disusuli dengan tangan yang sebelah. Okey. Slowly naik ke atas. Okey. Cuba dapatkan seluas yang mungkin bahagian otot atlet atau klien kita. Baik, teknik yang kedua yang ingin dikongsikan oleh saya adalah teknik Petrissage ataupun dikenali sebagai kneading. Dan teknik kneading ini sebenarnya dalam bahasa mudah dia, dalam bahasa Melayu adalah seperti teknik memuli. Okey, jadi kita letakkan minyak, ratakan minyak pada bahagian otot. Okey. Dan tangan kita perlu berada dalam keadaan sebegini. Okey. Berbentuk V ataupun U. Okey. Ni tolak dan pulihkan dia. Okey, pastikan kita mendapatkan keseluruhan bahagian otot. Okay, naik ke otot hamstring. Tadi gastrocnemius, sekarang kita naik pada hamstring. Baik. Jadi itu antara teknik Petrissage yang telah saya aplikasikan pada bahagian gastrocnemius dan juga hamstring. Okey, seterusnya saya akan tunjuk teknik Effleurage dan juga Petrissage pada bahagian upper body. Baik, teknik Effleurage ini adalah teknik yang pertama sekali atau dikenali sebagai teknik introduction kepada klien ataupun atlet kita. Dan first touch ini adalah sangat penting supaya atlet berasa dalam keadaan yang selesa, klien berada dalam keadaan yang tenang. Dan pada peringkat ini, kita perlu ratakan daripada bawah hingga ke atas trapezius ini dan hingga ke shoulder dan tarik ke bawah. Okay. Ingat, tekanan yang digunakan adalah bermula daripada rendah dan slowly naik dengan lebih tinggi. Okay, ingin dimaklumkan di sini bahawa kita sebagai sports mesua juga, kita perlu berada dalam keadaan yang sepatutnya, yang selesa. Okay, seperti mana yang sedang dilakukan oleh saya. Baik. Selesai satu kaedah dalam Effleurage. Dan kini satu lagi kaedah dalam Effleurage yang boleh kita praktikkan. Okay, sama seperti pada bahagian gastrocnemius tadi. Okay, letakkan tangan kita yang pertama, kemudian disusuli dengan tangan yang kita yang kedua. Okay, mulakan dengan perlahan-lahan. Dan slowly kita boleh meningkatkan tekanan sedikit demi sedikit. Dan harus diingat ketika kita melakukan sports massage ataupun urutan sukan, kita perlu memberi fokus 100% kepada atlet ataupun klien kita. Okay, jangan pula kita sambil mengurut, kita menonton TV, mendengar muzik dan sebagainya. Okay, fokus perlu diberikan sepenuhnya kepada atlet ataupun klien kita. Supaya tidak berlaku kemalangan. Okay, seperti tersalah memberi tekanan pada otot yang tidak sepatutnya, tersalah urut pada kedudukan otot yang tidak sepatutnya. Teknik urutan sukan seterusnya adalah berkenaan dengan teknik friction. Okay, dan teknik friction ini sebenarnya bertujuan bagi menguraikan masa-masa fiber kepada kedudukan yang sepatutnya, dan kemudian dia membantu dari segi proses vasodilation, iaitu untuk mengembangkan lagi saluran darah supaya darah dapat mengalir dengan lebih lancar. Okey, dan teknik friction ini adalah mungkin sedikit memberi kesakitan kepada atlet ataupun klien kita, di mana kita akan memberi fokus kepada mungkin terdapat bahagian-bahagian yang mempunyai muscle knot ataupun simpulan pada bahagian otot mereka akibat aktiviti yang berintensiti tinggi dan sebagainya. Okey, dan kebiasaannya kita melihat ataupun merasakan muscle knot itu berada pada bahagian-bahagian tertentu. Okey, kita akan menggunakan pada bahagian hujung jari ini. Okey, hujung jari ini. Dan kita akan menyokong dengan undominant hand kita, macam saya adalah tangan kiri, mencari spot ataupun tempat yang berlakunya muscle knot tersebut. Dan kita cuba menguraikan pada bahagian itu. Okey, contoh. Gunain, okey? Sakit sikit. Okey. Alright, harus diingat teknik ini kita membuat bulatan sedikit. Bermula daripada ringan kepada yang lebih berat ataupun yang lebih tinggi. Terus diingat teknik ini perlu dilakukan dengan perlahan-lahan dan kita perlu rilis dia pun perlahan-lahan. Kita jangan buat secara mengejut. Okey. Okay. Itu adalah salah satu contoh di bahagian gastrocnemius, di bahagian lower body. Okey. Kemudian kita akan memberi fokus kepada bahagian upper back body pula. Okay, let's go. Sekarang kita masih memberi fokus ke teknik friction. Okay, teknik yang ketiga dalam sport massage. Okay. Pertama sekali kita perlu mengenal pasti bahagian-bahagian yang mungkin mempunyai muscle knot. Okay. Semua okey ke? Okey, kita ada sikit lagi ya. Okay, alright. Okay. Selepas habis sesuatu urutan seperti friction itu tadi, okay, elok kita habiskan dia dengan effleurage. Okay, kita ratakan kembali permukaan yang telah diurut tadi. Baik, teknik yang terakhir dalam urutan sukan adalah teknik tapotamen. Dan teknik tapotamen ini dikenali sebagai teknik percussion ataupun percussion teknik. Kita letakkan minyak, okay, pada bahagian permukaan kulit. Sebelum kita habiskan, kita lakukan tapotamen itu, okay, kita buat sekali lagi effleurage. Okay, sekarang kita akan buat tapotamen. Okay. Sebaiknya kita cover, kita tutup pada bahagian otot itu tadi, gastrocnemius dan juga hamstring. Okay, yang pertama sekali adalah kita boleh melakukan sebegini. Okay, tangan kita seperti cupping, cup ataupun cawan, seolah-olah macam cawan. Okay, slowly. Dan naik ke atas, turun. Okay, seterusnya, genggam tangan sebegini. Okay, pusing begini. Dan begini, hacking. Ini adalah hacking ya. Okay. Selesai untuk bahagian lower back body. Sekarang ni kita pergi pada bahagian upper back body. Okay, sebelum kita melakukan tapotamen, kita akan lakukan teknik effleurage dahulu. Baik, setelah selesai melakukan effleurage, jadi kita akan melakukan tapotamen. Okay, pertama sekali kita akan melakukan cupping. Okay, macam ni. Angkat tangan segini. Pusing tangan begini. Dan akhir sekali kita akan buat hacking.
Dr. Munsif, sorry to interrupt you. So
Yeah.
we only have about 1 minute left.
Oh, right.
Okay.
Okay.
Yeah.
So no
Because
worries.
I want to spare some time for the discussion.
Question. Oh, yeah.
Yeah.
Sure. Okay, so I think I will give the link to all of you regarding my video, so you can watch after this, or maybe later. Okay. Stop share. Yeah, all right. So now back to you, Dr. Angga.
Yeah, thank you, Dr. Munsif. Ada yang mau bertanya mungkin dari mahasiswa atau dari teman-teman yang lainnya? Silakan.
Barangkali semua
Ini
lapar.
di chat box ini sudah ada pertanyaan ya dari chat Miko. Bagaimana pendapat Dr. Munsif tentang aplikasi sport massage untuk membenarkan atau membetulkan otot atau soft tissue yang sedang mengalami cedera, misalnya ankle sprain?
Okey, baik. Terima kasih kepada Jamiko. Okey, satu soalan yang bagus. Okey, baik. Pertama sekali, bila kita nak mengaplikasikan urutan sukan ini, apa yang saya cakapkan tadi, melainkan pada peringkat awal, kita perlu melihat tahap kecederaan seseorang atlet itu, dan kita kena pasti bila kecederaan seperti ankle sprain itu berlaku. Sekiranya ankle sprain itu berlaku dalam tempoh masa 72 jam ataupun bersamaan dengan 3 hari, kita tidak digalakkan untuk terus membuat urutan sukan di mana-mana bahagian tubuh badan kita. Kerana apa? Kerana ianya dikhawatiri akan menyebabkan kecederaan yang lebih teruk. Sebab apa? Dalam masa 3 hari ini sebenarnya salah satunya masa fiber kita sudah pecah. Ligamen kita ataupun tendon mungkin telah mengalami masalah. Jadi dalam masa tempoh 3 hari ini, otot kita dalam fasa untuk berada pada kedudukan yang asal. Okey? Dan sekiranya kita ingin mengaplikasikan apa-apa urutan, kita perlu melakukan ataupun kita boleh melakukan selepas 72 jam. Okey, pada ketika itu tiada masalah untuk kita melakukan apa-apa urutan mahupun regangan. Sebab kita kena ingat, pada bahagian seperti pergelangan kaki, pada bahagian tersebut kandungan ataupun komposisi otot adalah tidak banyak berbanding pada bahagian yang lain seperti hamstring, latissimus dorsi dan sebagainya. Kerana kita kena ingat pada bahagian pergelangan kaki ataupun tangan, kebiasaannya pada bahagian itu mengandungi jumlah ligamen dan tendon yang lebih tinggi berbanding pada bahagian otot yang biasa. Jadi kebiasaannya pada bahagian ankle sprain ini kita hanya melakukan regangan instead of urutan. Boleh juga melakukan urutan tetapi bukan urutan yang berat. Okey, bukan urutan yang terlalu kuat. Okey, cuba elakkan. So, that's it.
Ya. Jadi dalam 72 jam pertama ya. 72 jam pertama sejak cedera ya. Baik, mungkin ada pertanyaan yang lainnya. Jadi kalau misalnya sedang cedera justru harus dihindari ya, Dr. Munsif ya.
Betul sekali.
Silakan jika ada pertanyaan lagi. Mungkin kalau belum dari saya banyak pertanyaan nih, Dr. Munsif.
Okay, alright. Boleh je saya cuba jawab.
Ya, saya ini dulu ya. Mungkin setelah saya tanya nanti mungkin adik-adik ada yang bertanya. Pertama adalah apa sebenarnya perbedaan intinya ya antara sports massage ini dengan massage-massage yang lainnya? Karena kan kita punya banyak ya, ada massage yang tradisional ya. Nah ini sebenarnya kalau untuk sports massage itu apa perbedaan utamanya?
Okey, baik, perbezaan yang paling ketara. Okey, saya ambil yang paling mudah lah. Kalau di Malaysia ni ada beberapa urutan yang begitu famous lah. Selain daripada urutan sukan, seperti urutan Thai, and then urutan tradisional seperti urutan daripada kita panggil wak. Dekat sini famous dengan nama wak tau, kalau urutan tradisional. Biasa yang kampung-kampung kita pergi, kalau ada masalah otot atau cedera, kita akan cari wak. Dia macam tok bomoh lah, okay? Ataupun pawang. Jadi, kebiasaannya, apa yang membezakan urutan sukan ini dan urutan seperti urutan Thai, okay? Yang pertama sekali, fokus utama dia adalah memberi fokus kepada targeted muscle only. Sebab tu, pada peringkat awal, saya maklumkan bahawa urutan sukan ini memang memberi fokus kepada otot sahaja, tidak termasuk tendon and ligament. So that's why di akhir urutan sukan itu kita digalakkan untuk mengaplikasikan regangan ataupun teknik regangan seperti static stretching dan juga PNF stretching supaya kita dapat memberi recovery yang total, yang menyeluruh kepada tubuh badan. Okey, berbeza dengan urutan tradisional ataupun urutan seperti urutan Thai. Urutan-urutan ini memberi fokus kepada aspek nerve system kita. Dan harus diingat, bila urutan-urutan seumpama ini, kalau you all perasan, bila sports, bukan sport masseur, pemberi khidmat urut tradisional tersebut, dia akan memberi urutan tekanan yang lebih tinggi berbanding urutan sukan. Dan kemungkinan akan menyebabkan post effect lepas tu, iaitu kesan yang mungkin lebih menyakitkan. So harus diingat, urutan seperti urutan Thai ataupun urutan tradisional memberi fokus kepada aspek nerve system and then joint dan sebagainya. So ianya agak sedikit menyakitkan berbanding dengan urutan sukan. Di mana urutan sukan kita kena ingat, bila kita fokus kepada urutan sukan dan urutan sukan ini diberikan kepada mereka yang aktif. Seperti atlet. Kena ingat, atlet, bila dia habis game hari ni, contohlah dia lawan first round, hari ni dia menang, esok dia ada game lagi kan. Okey, kemudian dia menang lagi, dia akan masuk mungkin semi-final, mungkin akan masuk final. Jadi, urutan yang diberikan perlu berada pada intensiti yang rendah dan sederhana. Kita tidak boleh buat terlalu kuat. Kerana apa? Dikhawatiri menimbulkan kecederaan. Itu adalah perbezaan antara urutan sukan dan urutan-urutan lain. Terima kasih.
So, bagaimana caranya kita tahu bahwa urutan yang dikerjakan itu tekanannya itu sudah cukup?
Yes.
Tidak terlalu tinggi tadi ya, tidak terlalu kuat, cukup gitu. Bagaimana caranya?
Okey, terima kasih Dr. Arga. So saya menjangkakan soalan ini. Okey, jadi kita dalam dunia sport massage ataupun masseur, kita belum ada satu alat yang mampu untuk mengukur tekanan secara direct. Okey, daripada pemberi urut dan penerima urut. Jadi apa yang kita boleh lakukan adalah yang macam saya jelaskan tadi, kita perlu berkomunikasi dengan atlet kita ataupun klien. So that's why kadang kita boleh rasa bila terdapat satu beban yang tinggi pada bahu kita, bila kita tekan terlalu kuat, so definitely kesan yang diterima oleh atlet ataupun klien kita itu adalah tinggi. So that's why kita perlu, satu adalah kita perlu mengenali tekanan kita sendiri, rendah, sederhana ataupun kuat. Dan yang kedua adalah kita perlu berkomunikasi dengan bertanyakan, okay, adakah James, are you okay with this? Is it necessary with you now? Okay, can I go a bit tight? Can I go a bit pressure now? So that's why kita hanya boleh monitor melalui komunikasi. Belum ada lagi alat yang mampu untuk mengesan tekanan. Thank you.
Jadi komunikasi penting ya.
Sangat penting.
Ya, selain tadi yang ada aspek psikososialnya juga ya, psikologisnya ya dari massage ini sendiri. Oke, silakan ada yang mau bertanya? mungkin dari para dosen. Dr. Misbahul Munir ini dosen.
Oh
Dr.
ya,
Misbahul ini dosen.
minta maaf.
Tapi dia memang masih muda.
Oh ya.
Just finish his master degree.
Alright, nice to know you.
Ada pertanyaan lagi mungkin?
Izin tanya.
Ya, silakan.
Terima kasih Dok, mohon izin tanya. Kapan waktu yang paling tepat saat atlet mengalami cedera? Habis itu kapan waktu yang paling tepat saat untuk rehabnya gitu Dok? Kan atlet itu kan habis cedera kan dia sakit terus terapi. Ya kita melakukan tahap-tahapan waktu masyurnya. Habis itu rehab untuk penguatan ototnya itu kapan waktu yang tepat? Sedangkan kadang atlet itu ada waktu untuk final atau waktu tanding lanjutan. Sehingga kita sebagai masyur itu bisa menjelaskan ke atlet atau di saat sakit itu atau nunggu tidak ada masalah sakit baru melakukan penguatan otot. Gitu Dok, terima kasih.
Okey, baik. Terima kasih Saudara Ahmad. Baik, sebelum kita menamatkan sesi kita, okey, elok kita tahu bila dalam aspek urutan sukan ni ada dua fasa. Okey, satu diberi nama sebagai profilaksis. Okey, yang kedua adalah terapi. Okey, beza antara profilaksis dan juga terapi adalah profilaksis ini dilakukan pada sebelum latihan ataupun sebelum kejohanan dan dianya berperanan sebagai pencegahan kepada kecederaan. Berbeza dengan terapi adalah selepas menerima latihan ataupun melalui mana-mana kejohanan. Di mana terapi ini dilaksanakan selepas atlet itu mengalami kecederaan. Baik, jawapannya di sini untuk Saudara Ahmad adalah waktu yang tepat untuk melakukan intervensi ataupun program urutan sukan ini selepas kita kena tengok tahap kecederaan. Misalnya berlaku seperti Saudara Jamiko tanya tadi, kalau berlaku ankle sprain, memang kita tidak galakkan urut selepas 1 jam pertama hingga ke 70 jam. Dilarang sama sekali. Okey? Dan perkara yang sama juga kita perlu aplikasikan dalam situasi atlet Ahmad. Sekiranya kecederaannya terlalu teruk hingga menyebabkan dia tidak boleh melakukan teknik yang normal, jadi dia tidak boleh berbuat apa-apa melainkan berehat. Namun sekiranya hanya berlaku masalah seperti delay onset muscle soreness, okey, seperti lepas latihan terus dia rasa sengal-sengal, itu tidak menjadi apa-apa masalah. Tetapi apa yang harus diingat adalah durasi masa urutan itu, okey, kita perlu pertimbangkan. Sebab tempoh masa urutan sebelum latihan ataupun kejohanan adalah berbeza dengan jumlah masa selepas kejohanan ataupun latihan yang terlalu berat. Okey, kebiasaannya urutan sebelum mana-mana pertandingan kita hanya melakukan dalam tempoh masa 15 minit hingga ke 30 minit sahaja, tidak boleh lebih. Okey, berbeza dengan urutan selepas mengalami delay onset muscle soreness boleh dilakukan selama 60 minit. Okay, so kita kena beware of our athlete condition. So ingat, apa pun kita berpegang kepada prinsip 72 jam dan keadaan kecederaan tersebut.
Oke, jadi tergantung dari cederanya apa gitu-gitu ya.
Betul.
Tergantung dari cederanya apa, seberapa berat gitu ya. Dan juga kalau misalnya mungkin ringan itu bisa dilaksanakan, masih bisa dilakukan ya masasnya
Bisa.
ya. Tapi kalau misalnya sudah ada sprain atau misalnya sudah yang lebih berat daripada itu, ada cedera pada tulangnya dan lain sebagainya, rasanya harus ditangguhkan dulu ya.
Betul.
Di-delay dulu, di-postpone ya.
Ya.
Baik, satu pertanyaan terakhir, mungkin kita masih punya waktu 4 menit. Oh, 1 menit. 1 menit. Ada pertanyaan terakhir? Oke, Kayak mungkin ini Dr. Musif yang penting juga ya. Kalau tadi ada sport massage itu kan sebelum, during, and after ya.
Yap.
Atau in between competition gitu ya. Nah itu sebaiknya kalau sebelum kompetisi itu berapa jam biasanya yang dilakukan sport massage ini?
Okey, kebiasaannya sebelum pertandingan ataupun kita tahu kita nak buat centralized training yang heavy, kita akan lakukan selama maksimum 1 minit hingga 30 minit saja. And then in between matches, okay, jarak antara perlawanan A dan perlawanan B hanya 15 minit saja. Okay, don't go more than that. Dan untuk full recovery ataupun full terapi, selepas habis saja sesebuah kejohanan, okay, kita akan lakukan maksimum 60 minit sahaja.
Jadi totalnya kalau sport massage itu biasanya dilakukan 1 jam ya?
Ya, totalnya, betul.
Oh, cukup lama ya?
Ya, 45 minit hingga 60 minit.
45 menit sampai 60 menit.
Ya, sebab itu bila kita nak memberi khidmat urutan sukan, sport muscle, kita kena fit. Kita kena cukup tenaga, cergas dan bebas daripada penyakit.
Ya, dan mungkin tidak bisa juga menangani terlalu banyak atlet ya.
Betul, betul.
Ya. Baik, ada lagi mungkin kalau tidak ada mungkin saya bisa akhiri. Dr. Musif mungkin ada kata-kata terakhir before you finish the lecture.
Okay, so pertama sekali saya ingin mengucapkan jutaan terima kasih kepada Dr. Arga dan juga Universiti Airlangga sebab menjemput saya untuk berkongsilah tentang ilmu dan juga pengalaman saya dalam bidang urutan sukan, dan saya mengucapkan selamat maju jaya kepada pensyarah dan juga pelajar-pelajar dalam kelas ini. So yeah, maybe kita akan jumpa pada masa akan datang. So hopefully lepas ni kita boleh ambil gambar sekejap.
Boleh, boleh.
Thank you.
Hostnya siapa ya? Bentar.
Saya, dokter.
Ya, silakan. James ya? Dr. Munir sudah nggak ada?
My dapat is
Mungkin bisa dinyalakan semuanya ya. Minta tolong dinyalakan videonya. Ya, kameranya minta tolong di turn on dulu. Insyira, ada Tati, ada Samuel, Davin, ya, Nurma, silakan minta tolong dinyalakan dulu supaya kita bisa foto bersama ya. Alia, Mas Fahri, minta tolong Mas Fahri, Fahrul, Cesar. Polkes Mas Lulu juga saya minta tolong. Akmal Zidan, Akmal, Cesar. Dr. Adrianta, monggo dong kalau misalnya mau berfoto bersama, minta tolong dinyalakan videonya. Nurma. Ya. Oke, mungkin yang lain tidak on ya. Kita siap-siap dulu ya. Silakan James dipimpin untuk fotonya.
Baik. 1, 2, 3. Oke, sekali lagi ya. Sekali lagi. 1.
Pakai angka 1 ya, angka 1 ya.
1, 2, 3. Ya.
Ya, terima kasih banyak. Terima kasih banyak Dr. Munsif. Banyak sekali ilmunya yang disampaikan pada hari ini.
Thank you.
Kalau bisa fotonya dikirim di chat obrolan, Pak.
Oh iya, iya, siap-siap Pak Nova. Nanti kita sampaikan di mana, di chat. James, James minta tolong James ditaruh di.
Iya, biar bisa saya simpan.
Baik. Baik, saya akhiri guest lecture untuk hari ini. Terima kasih banyak kepada lecture kita, special lecture kita hari ini, Dr. Wan Ahmad Munsif, Wanpa ya, Wanpa. Semoga nanti ke depannya kita akan semakin banyak berkolaborasi. Saya akhiri, mohon maaf kalau misalnya ada yang kurang berkenan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
warahmatullahi wabarakatuh.
Terima kasih banyak Dr. Munsif dan teman-teman yang lainnya.
Ya, terima kasih. kasih ya.
Dr. Arga, nanti saya bagi personal slide tu dekat Dr. Arga.
Ya, siap, siap.
Okay, thank you.
Sama itu ya, YouTube-nya
ada-
ya,
YouTube.
YouTube channelnya ya.
Iya, YouTube channelnya atau Instagram gitu, Dok.
Ada, nanti saya bagi